since we have started our district coordinator CME under the guidance of Chairperson Dr.B.K. Singh, and especially under the guidance of our RSSDI Central Invigilator Dr.Sudhir Bandari, sir. So I'll request our Chairperson Dr.B.K. Singh, sir, to introduce our Chairperson and guest of honor and chief guest for this meeting. So over to B.K. Singh, sir.
Thank you. Thank you.
Good evening, all of you. First of all, I thanks Subhash for wonderfully organized this meeting, and I welcome our chief guest, Dr. Sudhir Bandari. He is the head of the Department of Medicine at Sawai Madho Singh Medical College, Jaipur. And he is the prominent diabetologist, and he is well known to all of us, and presently working as executive in government executive committee of RSSDI, and he is also in charge of all activities of RSSDI Bihar chapter as a central coordinator. And I also welcome our guest of honor, the founder, chairman of RSSDI Bihar. Without him, the RSSDI or diabetology or the research cannot be thought of. And Dr. Kumar sir. And I also welcome all the speakers, particularly Dr. Vijay Patni from Calcutta, Dr. Amit Kumar Das, one vibrant speaker from Muzaffarpur, and of course, our scientific committee chairman and the speaker in this present CME. I also welcome Dr. N.K. Singh, the chairman of RSSDI Jharkhand, well-known personality, and our this is particular in Dr. R.R. Burma, and we have most important, as Darbhanga is the most important place in Bihar, and we want to energize the Darbhanga, and Dr.S.C.Jha is from the Darbhanga, and Dr.S.C.Jha is the head of the Department of Medicine of Darbhanga Medical College. Is very keen interest in this diabetic subject, and I have talked several times to him, and he is quite associated with all activities of the district coordinators and the activities of the RSSDI. And the district coordinator of Darbhanga, Dr. Manish Kumar, and all those present here, Dr. Hem Shankar Sharma sir, the chairman-elect, and Supriyo, our this research committee chairman, and we are very soon we are going to launch our research activity, and I just thank to the central committee that Bihar chapter has received the rupees 5 lakhs for the research activity. So I really thanks all of you, and I welcome all of you. And now I hand over the mic to the Subhash.
Thank you.
Request our chief guest and the guest of honor to say a few words.
Thank you, Chairperson Dr. B.K. Singh, sir. And I would request our guest of honor, Dr. Ajay, sir, to say few blessing words for our RSSDI Bihar chapter. Over to Ajay, sir.
Dear colleagues, it's really a great pleasure to have Dr. Sudhir Bandari from Jaipur, who is a very close friend of mine, sharing with us. And I'm sure his expertise, his guidance will lead us to charter a new path in the research in diabetes in Bihar. The carefully chosen topics are going to be very enlightening to the audience. And in this audience, I can see that most of the doctors who are present, they are regularly coming to these CME programs, but I specifically welcome Dr. U.C.Jha, the head of the Department of Medicine of Darbhanga Medical College in this meeting, because he is one who will continue to inspire large number of young doctors, particularly the postgraduates and resident doctors. Contribution of people from medical college is going to be of extreme importance in any scientific endeavor, and I'm sure his presence will energize the entire system. The topics are extremely important from clinical perspective, from clinical practice point of view, and therefore, without wasting any time, I wish success to this program, and I hand over mic to Dr. Subhash.
Thank you, sir. Your blessing means a lot to all of us because we really believe that you are the Chanakya of diabetology for not only India, but across the world. And your presence makes a large difference in our future endeavor. Now I'll request our chief guest from Jaipur to have few words of blessing to our chapter and our research work, which we are going to start shortly. So I'll request Dr. Sudhir Bhandari, sir, to kindly say a few words to us, to our chapter.
Good evening, all the esteemed office bearers of the Bihar chapter, Dr. Ajay, who has been a brilliant speaker, scholar, academician. I've been always an admirer of Dr. Ajay, who has been a pillar in the diabetology in country. I really extend my profuse thanks and gratitude to Bihar chapter for having invited me. The topics chosen today are very impressive, and I'm sure this is the need of hour. And as all of you know, that these days we are heading towards a reversal of diabetes. You know, treating diabetes is an art. It is not only the giving a pharmacological prescription, but our endeavor should be to prevent the complications. If all of you realize that if you see 100 patients, probably most of your patients will have either retinopathy or peripheral neuropathy or early nephropathy, etc. The rising incidence of ischemic heart disease because of enhanced inflammatory markers in type 2 diabetes, the nephropathy is on rise. Probably we have to have very holistic approach to address the diabetic issue. You know, there are multiple etiologies which is giving rise to the hyperglycemia. Our treatment selection should be very precise, patient-centric, and very scientific. You know, all type 2 diabetic patients over the period of time become insulinopenic. The day diabetes is diagnosed, 50% people, most of our 50% beta cells are there. And as the disease progresses, they become insulinopenic. So we need to have a protocol, the patient-centric protocol, when to use which drug, when to introduce insulin, when to use the drugs which are independent of the beta cell. So today's topic chosen in your CME are wonderful. They will increase the insight in the management of diabetes. I thank Bihar chapter officials for having invited me. Probably I love to visit once Patna. Dr. Ajay has been a great friend. We are a great speaker. In fact, he carries a great status of his in the field of diabetology, endocrinology, and medicine. And I'm sure we can, it will not be too much on my part to say that, yes, I've been addressing the CME of the state to which the Ajay belongs to. I welcome all the speakers. I'm sure you are going to deliver the great message to all our colleagues and all our fraternity. So I will conclude by saying that managing diabetes is an art. We need to make management of diabetes so patient-centric, and we should ensure that diabetes should not affect the longevity and quality of life. And our endeavor should be to make the patient's life complication-free, fine-tune the diabetic management and the drug treatment selection, along with the advice for lifestyle modification, along the exercise plan, should be in such a way that patient leads the best quality and the longevity of life without any complications. And winning situation will be when we can give a patient complication-free life. And I think patient education holds a big role in our endeavor. Thank you very much to all of you, sir. And thank you. I'm humbled and honored to be part of your CME. Thank you.
Thank you, Sudhir Bhandari, sir. It is a word which we really wanted from a person like you. I have seen you and the way you have been so humble and to the ground that you have encouraged our endeavor and blessed us with your presence to this meeting. We started this meeting with you. This is one of the first meeting which we are starting post.
It's a wonderful. I love to be part of every meeting of yours, and any way I can contribute, I think we'll be very happy to be associated with Bihar chapter. I'm sure all of you are doing a great job, sir.
Thank you. Thanks a lot, sir. Now it's time to introduce our Chairman Scientific Committee, without which this meeting would not have been possible. The topics which all decided and selected was Dr. S.C.Jha. So I'll welcome S.C.Jha, sir. He's a professor at our Darbhanga Medical College, and he has been a thorough academician and our governing body member as well as scientific committee member for Bihar chapter. Over to S.C.Jha, sir.
Good evening, respected Ajay sir, Sudhir Bhandari sir, and all seniors present, Dr. B.K. Singh, Dr.Subhash Kumar. Firstly, I would like to thank RSSDI Bihar chapter for giving me this very highly responsible job of chairman of scientific committee. As the first initial webinar web conference, I decided to start with the basics, the lifestyle modification, which despite so many researches, so many advancements in the pharmacological therapy, bariatric surgery and all, remains the cornerstone of therapy of diabetes mellitus. And so the chapter which I have selected is pre-diabetes, diet and exercise. As we know, all of us, all across the globe, there is tsunami of type 2 diabetes mellitus. Number has multiplied 4 times in last 3 to 4 decades. And most of this tsunami has taken place in middle and low income countries like India. So this is a major challenge before us. And as Dr. Sudhir Bhandari has told, that at the time of diagnosis, many patients have complications. So this is the time to take the challenge head on and start with lifestyle modification. For the first topic, I will introduce the chairpersons. I am honored that Dr. U.C.Jha, HOD Department of Medicine, has accepted my invitation and request to join, and he will be chairing session on the first topic, pre-diabetes, its clinical importance. Needless to say, most of us, the number of pre-diabetics is beyond imagination, and how we can prevent pre-diabetic from developing diabetes is the major challenge. So Dr. U.C.Jha and Dr. B.K. Singh will chair the session, this important session, for which a brilliant diabetologist, a brilliant physician from Kolkata, Dr. Vijay Patni, will be there to enlighten us on this very, very important subject. I will hand over the mic to Dr. U.C.Jha sir for introducing the topic and the speaker, and Dr. B.K. Singh, the co-chairperson. Over to Dr. U.C.Jha.
Some audio issue, I think. Dr. U.C.Jha sir, are you audible? Are you able to connect? Otherwise, I'll request Dr. B.K. Singh sir to unmute and introduce our eminent speaker, Dr. Vijay Patni.
Thank you, Subhash and Dr. S.C.Jha sir. First of all, I would like that the pre-diabetes, the one of the most important clinical condition, where reversal is the one of the subject which is now going on all across the world. So reversal is possible only when the pre-diabetic conditions are there easily. And for that, that is a very important topic. Why pre-diabetes is important? What are the conditions where you can start treatment? What are the conditions where lifestyle modifications are important? And how clinically it is significant that a person having the pre-diabetes can go towards
just an
diabetic.
interruption. I have
Yes.
forwarded the CV of Dr. Vijay Patni to you on WhatsApp, and kindly go ahead. Kindly go ahead.
Okay. To introduce the speaker, Dr. Bijay Patni is a consultant physician and cardiodiabetologist, HOD Diabetes Wellness Clinic, Kolkata, founder Diabetic Research and Welfare Association, scientific chairman, 7th Annual Conference, and the faculty of the Omron Academy and scientific chairman and course director of Diabetes Activity Certificate Program, and many more. He is awarded GAPI PG honors for the month September 21 and participate in various study and clinical trials like IDN, PS, and the KID and the GUARD and so many. So Dr. Bijay Patni is well known as far as Bihar is concerned and is very close to the Bihar. And now I request Dr. Bijay Patni to start the talk.
Thank you, sir. Thank you, team RSSDI Bihar chapter. First of all, I am fortunate to have Dr. Sudhir Bhandari and Dr. Kumar today in this symposium. And we have so many seniors out there, and I think I know most of them, and I'm fortunate really to be in this particular CME. Thank you, Dr.Jha, for inviting me. Thank you, Dr.Subhash, Dr.Singh, for giving me this topic as well. So as you already said that this is such an important topic, pre-diabetes, and the whole thing starts with pre-diabetes. So it's apt that we have this topic at the start of the new program which you are trying to enroll. I think you're starting from pre-diabetes and you're going ahead with the CMEs, which is going to incorporate most of the part of the diabetes. So I consider pre-diabetes the harbinger of all the evil. People may not agree, but as Dr. Singh has rightly said, this is the state where reversal is possible. And the whole idea should be to reverse this pre-diabetes to normoglycemia. Because we are sitting on a diabetic pandemic, and we have a huge population who have already been diagnosed, and the similar number of people who are still undiagnosed. So you can well imagine any problems?
Just PPT mode, sir. Because
okay, sorry. Yeah. I have not started the at all. Just a minute. Is it visible now? Is it okay?
Yes, done. Thank you, sir.
Fine. So, so basically, this is what I was telling. This is the real state of whenever you consider diabetes, the pre-diabetes is so important that this is the area where we need to take proper action and try to identify those individuals who are falling in this particular group, and thereafter manage them such that they turn into normoglycemia, because there is a huge economic as well as the healthcare infrastructure which our country is facing as far as diabetes is concerned. So let's go. What's pre-diabetes? All of us are aware of the fact that it's an intermediate stage between normal glycemia and diabetes. And not only that, it is highly prevalent, particularly in obese individuals, but not so to be considered in India in particular, that we have lean pre-diabetics as well. But the problem lies with the definitions of pre-diabetes. Even in current practice, they are based on different cutoffs, whether it's HbA1c, fasting, or PP, to our glucose. So the major challenge definitely lies with the lack of guidance on when one definition might be preferred over another. Today, only the ADA standard of care came, and then AD had its own definition, and they have planned out the therapy accordingly or the management of pre-diabetes. Randomized clinical trials have demonstrated that lifestyle and pharmacological intervention can be the cost-effective, prevent diabetes, and improve cardiovascular risk factors in adults with pre-diabetes. So my whole job will be just about telling you a little bit about pre-diabetes and why it's so important. Because the next part, that's the management of pre-diabetes, and thereafter reversal, the onus of reversal will fall on the two other speakers of today's program, who are going to concentrate on the major intervention therapy for pre-diabetes. So the term pre-diabetes is used to identify those individuals who are at risk for future diabetes. But pre-diabetes is also associated with high burden of cardiometabolic risk factors and is associated with poor outcome. Now, this is the importance of pre-diabetes. It's just not that it is a preliminary to going forward to diabetes, but it itself is a burden of cardiometabolic risk. The increasing prevalence of prediabetes globally is a major public health concern and does not bode well for the growing epidemic of diabetes and its complications. Rather a pandemic, I would say so, because globally it has risen to that label. Now, this is the history basically. When what is first concept came, that was in 1970s when the concept of pre-diabetes emerged. And that was to indicate identifiable stage of glucose dysregulation. Thereafter, if you look in 1979, the National Diabetes Data Group used the term pre-diabetes to designate the impaired glucose tolerance. And that was taken or adopted by the ADA and the WHO. Subsequently, the ADA in 1997 and WHO in 1998 introduced the additional category of impaired fasting glucose. And then there is a different fasting glucose nowadays being considered. That time it was considered to be 110 by 125, which was basically thought about as the pre-diabetes. But then in 2003, the ADA issued new IFG diagnostic criteria where it brought down the range from 110, 125 to 100 to 125. In 2010, the new hemoglobin HbA1c based definition of pre-diabetes was introduced by ADA along with the first recommendation for the use of HbA1c for diagnosing diabetes. So basically, this is how the concept came along. Now, let's look at the global prevalence. That is where probably we don't have that global prevalence data. We have the US data. We might have some studies with India as well, but we don't have a globally authenticated true picture of where the pre-diabetes stands. In 2019, the International Diabetic Federation estimated the global IGT prevalence at 7.5% for both men and women. The later estimates correspond to approximately 374 million adults, which is acceptable presently as what the pre-diabetes stands at. And if you see, the majority of them are below the age of 50. So that again gives you a clue that how important it is. It's going to affect the younger people out here. And about 30% of the patients are within the age group of 20 to 39. So it's no more an elderly disease, neither the diabetes nor the pre-diabetes. It is occurring much earlier in the second, third, fourth decades. The vast majority of individuals with pre-diabetes reside in low and middle income countries. The North American and Caribbean regions have the highest IGT prevalence, and the European region has the lowest prevalence. Unfortunately, India is not counted here, but India has equally great number as far as pre-diabetes stands. Now, this was the US population. That's about 80 million out of 104. If you try to enroll all the classes of diabetes, whether it's type 1, type 2, or undiagnosed diabetes and all those stuff, 80 million of this population are in pre-diabetic stage as far as the US population is 2010 data. Now, if you look at the what I said, there was an issue with the definition per se, and that is how the pre-diabetes prevalence is going to differ as well. So this is what the chart shows. If you look at the AEC, HbA1c, ADA, HbA1c, ADA, WHO 2R glucose, WHO fasting glucose, and ADA fasting glucose, the prevalence is variable as per the definition. And you can see it can range up, it can go up to 43.5%. So this is the problem. If you consider WHO criteria, maybe the prevalence will be less. And if you consider the ADA criteria, the prevalence will be more. Similarly, if you look at the hazard ratio for the association, different definition of pre-diabetes with incident diabetes, or with CKD, or with CVD, or all-cause mortality, again, they vary as per the definition of pre-diabetes. Now, this is natural history. All of us are aware of the fact that, yes, this progress in this way, the insulin resistance is the culprit. And it is this problem which is at the pre-diabetic stage. So if you are trying to correlate this pre-diabetes with all the cardiometabolic risk, along with the increased incidence of CVD or a marker of CVD, then it is the insulin resistance probably which is going to play a major role. Now, this is the definition. As per definition, if you look at the fasting and fasting oral glucose tolerance test, the pre-diabetes is between 100 to 125 as per ADA. And the pre-diabetes as far as OGT is concerned is 140 to 199. Similarly, if you go to the diagnostic of, if you this is the same thing. And if you look at the HbA1c level, then obviously it is between 5.7 to 6.4%, where pre-diabetes become important. The one factor which we need to understand that HbA1c is good, ideal for screening pre-diabetes, but never take that as a face value. The diagnosis of pre-diabetes, which may manifest as IFG or IGT, should be confirmed with glucose testing. So that's very important, even if you because there are a lot of issues interpreting HbA1c, the hemoglobinopathies, etc., could play a part, and we might end up with a error report as far as HbA1c is concerned. So you need to confirm it with the either IFG or IGT in order to diagnose the pre-diabetes. Now, so how do you go about it? Should be the universal screening. Probably it's not very not possible. We should always try to do is some countries like India and all, it won't be economically viable. And in most of the developing countries where pre-diabetes found to be rampant, it's not possible. So you need to screen them in the high-risk group. It's the same for diabetes as well as pre-diabetes. And obviously, I'm going to enumerate those. If the age is more than 45 years without any risk factor, family history of type 2 diabetes, now this age has been cut down to 35. I think Dr. Kumar can always give an idea on that. It has been cut down to 35. Family history of type 2 diabetes, CVD, overweight, the BMI more than 30, 25 to 29, and plus other risk factors, sedentary lifestyle, member of an ethnic group where it is more commonly seen, dyslipidemia, where it's part of the metabolic syndrome, and PCOS. If you have the markers like acanthosis nigricans, NFLD, hypertension associated, history of gestational diabetes or delivery of a boy weighing more than 4 kgs, who are on antipsychotic for schizophrenia or bipolar. So there's a gamut of all those conditions where you can consider these individuals at risk, and they should be screened for pre-diabetes, because it is here we need to catch them young. When we say that, catch them at the pre-diabetic stage, so that we can appropriately manage this, so that they can reverse themselves to normoglycemia. Now, the more so important now, if as far as pre-diabetes, what Dr. Jha wanted me to say was what you are going to say on pre-diabetes. So I would say and reiterate the fact that is all the cardiovascular disease is a major issue even at the pre-diabetic stage. We all know that before the onset of diabetes, the macrovascular scenario starts changing in a patient. So that the whole organ system, as far as these particular organs are concerned, they start having those changes even at the pre-diabetic stage. So they actually starts developing, leading to the increased risk for cardiovascular disease, and the pathology behind happens to be the insulin resistance. I think this is not the correct slide. Anyway, I'm going to say I think it's not visible to you all. So basically, insulin resistance is one which is linked to the range of CVD risk factor, and that is the underlying pathology happens to be endothelial dysfunctions and vascular inflammation. So basically, these two pathology are responsible for all the atherosclerotic events or the hypertension or whatever you call it, and then that may lead to increased CVD. So just at the base, I would say that endothelial dysfunction and vascular inflammation plays an important role when insulin resistance is around, and that culminates into the CVD. And the same thing, obviously, the pre-diabetes are also susceptible to the CV events, whether it's in the shape of stroke, myocardial infarction, peripheral vascular disease, congestive heart failure, inflammatory, this congestive heart failure and all. All the CV events can get aggravated or can culminate. This pre-diabetes can culminate itself without being in diabetic phase. they might have this through the major contributor being endothelial dysfunction. Now, this is one thing which would give you an idea that the risk of diabetes increases with increasing HbA1c. So if you see this, this particular window, that is 5.7 to 6.4, which we consider pre-diabetes, the individual, if it happens to be between 6 to 6.5, has a much high chances of getting into diabetes. And those, obviously, once it is more than 6.5, then it is diabetic. But if you compare that with the earlier marker, that is 5.5 to 6, the chances of that individual getting into diabetes is less. And those who are in between 6 to 6.5, their chances of getting into diabetes is much more. And this is the prospective observational study way back in NEGM, was published way back in 2010 in NEGM on 11,000 patients without DM or CVD. And if you look at meta-analysis of 18 clinical trials, the risk of cardiovascular clearly seen both the types, impaired fasting glucose and impaired glucose tolerance, that the risk increases with both the events, and this is on the basis of 18 clinical trials. So that's clearly is a pointer that whatever importance we need to give pre-diabetes, with the whole idea and concept that this is a harbinger for CV disease. So we need to manage this pre-diabetes as we give that as a similar way as we give to diabetes. So the pre-diabetes, obviously the management happens to be mainly lifestyle modification. Now even the standard of care has come out with the recommendation of metformin as one of the therapy in certain group of population. But basically it's a lifestyle modification, which most of the studies have clearly shown, the prevention studies, that it is responsible for most of the cases for prevention of diabetes. So these are the various studies, the prevention studies, the Finnish diabetes prevention study. This was done in 522 overweight and obese patients with impaired fasting glucose. And you can jolly well say the lifestyle was the intervention which was done. And for 3 years, they were followed up, and it clearly showed that they reduces the risk of developing diabetes mellitus. So lifestyle, by any studies, which I'm going to enumerate few of them, and it's a clear-cut intervention measure which one need to undertake in pre-diabetes, and that should be strictly followed. So a lot of counseling, education, etc. need to go while managing pre-diabetes. It's more a collaborative effort which we undertake for diabetic patient. The similar kind of collaborative effect, even a psychological support, need to be given to a pre-diabetic patient. And this was a study, Japanese, 458 Japanese men with impaired glucose tolerance randomized to standard lifestyle intervention or intensive lifestyle intervention. You see those intervention group has a lesser chance of developing into diabetes. So again, it's like reiterating the fact that in various studies over time, the prevention studies have clearly shown that lifestyle modification has a much greater role to play, and that should be strictly adhered to. And this was again we all talk about the this Indian study, and here I've clearly showed that the lifestyle is, even if you add metformin, you're not going to benefit much with the addition of metformin. It's almost similar, whether it's lifestyle modification per se or a metformin lifestyle combination. They almost have a similar kind of impact as far as the reducing the impact of incidence of diabetes in these pre-diabetic patients. They all were Indians with impaired glucose tolerance, and they had 3 arms, where the control arm, metformin, and lifestyle and modification, and metformin and plain lifestyle. So it clearly proved that the lifestyle is the crux of all the good management practice as far as the pre-diabetes is concerned. This was the stop NIDM with acarbose. This also showed a benefit, and this clearly showed that it reduces the risk of diabetes. So I'm not going to detail in all this stuff. Basically, what it showed, over 3.5 years, it was followed up, and no less than 1,400 patients were taken in, and they showed acarbose also showed a reasonable kind of impact as far as reducing the risk of diabetes. Similarly, the DREAM trial, which added on another stuff, that was that not only reduce the risk of diabetes, but also reduce the risk of death. That was with rosiglitazone ramipril trial, and this was performed on IGT and IGF, both impaired fasting and impaired glucose, but without known CVD. So again, this also comes with the fact that the glitazones might have a role as well. ACT now, which is the glitazone, bioglitazone, where it was involved, and they showed that a relative risk reduction of 72%. That was a huge in impaired glucose tolerance patient or impaired fasting glucose, and it was followed up at 2.4. So overall, what we could say with the various prevention studies that lifestyle along with sub-pharmacotherapy has been able to reduce the incidence of risk of diabetes in pre-diabetic stage. But still, what we are, the rule of the thumb happens to be that it is to be the lifestyle modification which need to be the intervention which is needed for pre-diabetes. And these are the whole gamut of various trials, which were the prevention trials. And you can see almost lots and lots of drugs were used. We have already told about pioglitazone and acarbose and rosiglitazone. There's another study, voglibose and all. So basically, in spite of all the studies, still the recommendation goes for what our two speakers are going to speak on subsequently. These are the various other trials. Similarly, we consider the Indian DPP and the Finnish trial, and all have clearly showed that lifestyle is the whole idea behind managing the pre-diabetes is lifestyle. So this, if you just look at this algorithm, so basically the same thing is again re-emphasized, that lifestyle modification where you have assisted weight loss should be the ideal way of managing. If there are other CVD risk factors, they need to be managed along with the HbA1c or the glucose glycemic targets. Weight loss therapies are plus minus. They have not been recommended, but if there is a weight loss therapy which you need to initiate in this group of patients, they can be thought about. There is no recommendation as such. And these, once they progress to hyperglycemia diabetes, obviously you have to follow the algorithm. Anti-hyperglycemic therapies, obviously, once such a recommendation is there, that the BMI is more than 30, or the patient is having gestational diabetes, or in those cases, metformin has been recommended. So otherwise, I think still we have to depend on the lifestyle, which have to be followed very strictly with a lot of impression on the patient. And it just cannot be say you have to undertake a lifestyle modification or you have to do those changes. You have to follow up. The follow-ups have to be seen. You have to call them to the clinics or remotely, wherever it is, and try to emphasize that this has to be continuously undertaken so that we can achieve that normoglycemia. I think, as because I'm not going to management, because Dr. Jha has clearly told me it's we have diet and exercise to be talked about separately. So what I want to say from my talk, or I want to give this message, is that pre-diabetes should not be taken lightly. It is the harbinger of all the evil. I have said in this. It is a cardiometabolic risk. It can lead to CV events, so it has to be managed very, very tightly. And the whole idea of reversal of to normoglycemia should be entertained at this level. Thank you, friends. Thank you, sir. I'll stop sharing.
Thank you, Dr. Vijayapatni. Excellent talk. I request Dr.S.C.Jha to say something. Dr.S.C.Jha, sir.
Thank you, Dr. Patni. And you have given a very enlightening talk, especially on pre-diabetics. So this pre-diabetic is the iceberg of full diabetes. So controlling the pre-diabetic stage, it will be much more beneficial for the management of over diabetes, especially the lifestyle modification that we emphasize along with pharmacotherapy. I think so. You have given much more stress on the macrovascular complications related to the pre-diabetics. So there are so many persons who are no history of diabetes before and to us with macrovascular complication, acute MI, cerebrovascular accidents. And when we investigate them, they are found to be diabetic or in pre-diabetic stage, B1C, around about more than 6, around about 5, that is the cutoff, as you have discussed. So thank you very much for such a nice and clear-cut concept on the pre-diabetic stage and the emphasis that the pre-diabetic
I think is disconnected because of.
Okay. Dr. Patni, one question is that, one of the slide you have said that the chances of conversion of frank diabetes is more when the HbA1c is 6.2 to 6.4. In that background, you can think the prevalence, regarding the prevalence, if the impaired fasting glucose level is 100, the prevalence goes up to the 43 or 43%, 43.6%. So do you think this 100 or 110, which is important for our Indian population? Do you
I think the
100 fasting?
HbA1c of 6 is 126, right? It collaborates to 126. So basically what they wanted to show from HbA1c data that those who have a higher HbA1c even in the pre-diabetic stage, they are more chances of them converting to diabetes is there. And rather those who are on the lower scale, their chances of converting to diabetes, their chances are there, but they are less. This is what that particular data wanted to show.
Dr. Patni, I want, what is, do you think it is 100 impaired fasting is appropriate or it is 110? What do you consider it the more appropriate for our population?
I think the appropriate, obviously, as we all know, if you really want me to say which is the one which gets converted, then obviously you will say it little higher there. But the WHO has a different criteria and AD has a different criteria even today, right? So considering that, the 100 will be much better off, because if you catch them early, at least you can initiate some kind of measurement. See, ऐसा नहीं है कि 100 और 110 में बहुत बड़ा difference होने वाला है. But if you can get them at 100, you at least initiate some kind of measurement so that they can really convert into hypoglycemia, normoglycemia. I mean, this is my take. And I think we have seniors like Dr. Bhandari and Dr. Ajay, sir, they can say more about it.
Sir. Dr. Raja, sir.
Hello, thank you, Dr. Patni, for that excellent talk, particularly highlighting the importance of IGT and its corroboration with the cardiovascular outcomes. I think the most important thing that you have taken us through the number of trials which have been done to highlight the importance of lifestyle intervention as the sheet anchor of management of pre-diabetes. I don't have to say much, except I have to protest for a particular statement that you made right in the beginning of your talk, that there is paucity of data about prevalence of pre-diabetes in India. I think no other country in the world has that amount of data which India has on prevalence of pre-diabetes and diabetes. We should not forget that the INDIAB study and many other studies, INDIAB of course is the mother of all studies, they have not only absolute data from the entire country, but they have been published in the most impactful journals of the world, like Diabetologia, Lancet Diabetology and Endocrinology, and the prevalence of diabetes in India is 7.3%,
and prevalence of pre-diabetes is 10.3%. Dr. V. Mohan was the chief investigator recruited by ICMR. I was the principal investigator for Bihar. Dr. Vinay Dhandania was the principal investigator for Jharkhand. And similarly, there were one investigator for every state. And this was an extremely scientifically conducted study with Google mapping of rural and urban areas. So I don't think we have any doubt about the prevalence of pre-diabetes in India. We have very clear idea about diagnosed, undiagnosed pre-diabetes, diabetes, and almost all the metabolic associations of diabetes. Humongous amount of data published in most respected journals of the world. Thank you very much.
Yeah, I take back my words. I know about IDEP study. Actually, this was on 2020 article, which was published recently. And unfortunately, I took that article as the base. So that is why I know about the Indian the data, and we have this data actually. And I take back my word. Thank you.
If we simplify simply, that we know the data that on an average, it is 7.3% diabetics, right? And 10.3% for pre-diabetes. So if you focus jointly, you will find out that the pre-diabetics have overpowered or overruled the numbers statistically. So why don't we just knock them down straight away? And the policy is not only the control of diabetes, it is rather changing towards the control of pre-diabetes. Identify pre-diabetes and just nail them initially so that everything will be simplified and it will be a much better perceptions. So that is always a very important aspect. Rightly pointed out that it is the tip of the iceberg, but now we know the total strength of the iceberg. It is not only the tip, it is not that big as the iceberg 1/11th, and it is not that exactly. There are differences of approximately 3 to 4% differences are there, but this is a very big difference considering our population. And we must focus straight away to find out. And what B.K. Singh has said, there is a difference between 100 and 110. You said rightly that WHO and ADA have two different classifications. I personally do not find any much difference between 100 to 110. And if we just focus simply on 100, our catch will be catch them young, catch them early, so that you can reward them and they can finally land into the so controversial talk of the reversal of the diabetes, right? Scientifically, we all know that diabetes at the present conditions or situation cannot be reversed. What we mean that they can be controlled so well that the HbA1c level should go much less than 6% or so. Secondly, the importance, even if the blood sugar level is less than 100, and if the HbA1c is more than 6.5, is labeled as a diabetic, there is no confusion about this. HbA1c has always surpassed in the assessments of leveling someone as a diabetic. So even if the patient is having 80 milligram of blood sugar fasting and an HbA1c over 7%, he should be treated, in my opinion, with particularly those drugs like metformin, which do not cause too much of hypoglycemia, and not using the drugs like the GLP-1 and all other combinations which can lead to more of hypoglycemia. This is my opinion. And I think Dr. Sudhir Bhandari, if he is there on the line, he can just elaborate on these issues, sir. Or if he is not there, Ajay, sir.
I think Dr. Bhandari is here. Has he left?
He's there, but he's on mute, maybe some meeting. So maybe I'll request the
okay. So just one word, what Hem Shankar said, if Dr. Bhandari is not responding right now, I totally agree with what Dr. Patni was saying, that the idea between 100 and 110 is not a very big difference. It is basically to sensitize that something has to be initiated. The lifestyle modification has to be initiated. The whole issue is that whether lifestyle modification should take the priority or metformin, pioglitazone or acarbose or whatever drug has to take precedence. Now imagine when you are talking about 58% reduction with lifestyle modification and 31% reduction with metformin, 72% reduction with pioglitazone, it's a very difficult choice. The other problem, the practical problem is that you are already criticized in the society that you are decreasing the diagnostic criteria to increase the umbrella of treatment. You are trying to help the pharmaceutical houses. And if you start prescribing medicines to patients of pre-diabetes who obviously are asymptomatic, it's going to again create more problems. So I personally think that the data and the practicality both suggest that we should prioritize with lifestyle modification. And I'm sure two subsequent speakers are going to throw light. And also, if you remember the Roy Taylor study from Britain, who has shown about the reversal of diabetes with terrific amount of dietary recommendations, etc., I think this has opened a new chapter where role of medicines in pre-diabetes is going to be less and less. It's more scientifically directed towards diet and exercise, which is going to be extremely helpful. Thank you.
Over to S.C.Jha, sir, for the next speaker we introduced.
After a very brilliant talk on a very important topic, there is some change in the schedule, and Dr. A.K. Das has requested that his topic should be kept the last. So this topic will be prescribing type 2 diabetes mellitus, prescribing exercise in type 2 diabetes mellitus, and the chairpersons will be Dr. N.K. Singh, and who is a well-known figure from Dhanbad. We don't have to detail his achievements, and most brilliant of all, he has contributed to the scientific development by opening up the CME channels. And I will like Dr. N.K. Singh and Dr. Manish Prasad from Darbhanga to take over, please.
Thank you, Dr. Jha, for excellent words. Basically, Bihar is always in my heart, and I remember the days when Dr. Ajay was the chairman of the United Bihar and Jharkhand, and I was secretary, and I think we surpassed in the CME numbers. So really, it is very good to have here you all. So I think the second talk is going to be a very eye-opener, because many times we are listening about the exercise and diet. And today I invite with my co-chairman, Dr. Manish, itself our scientific secretary of the RSSDI Bihar, Dr.Sudhir Chandra-Jha. I think everybody is aware he is the associate professor in the Department of the Medicine from the Darbhanga Medical College. He has a teaching experience over 25 years and publications in different journals, membership of all like prestigious organizations like API, CSI, CCDSI. Also honored as a best speaker in the API Bihar chapter for the year 2018 and 19. So he's a noted speaker now. I see in most of the conferences, state level or national level. So I have great pleasure in inviting Dr. Jha, as this topic is very close to my heart. And definitely exercise, as we are just Dr. Patni told about the pre-diabetes, and we will also listen about the diet later on. But I think I remember one very big, I think just I am from the, I think one very important study, he was telling at the ESD that if you combine both modifications like diet and exercise, we will achieve a bigger goal. So let us, without wasting time, the topic is exercise as prescription in type 2 diabetes. Dr. Jha, please share and start. Good.
Respected Chairman, sir, seniors and dear friends, as Dr. Vijay Patni has said, the stage right for these topics, and Ajay sir has emphasized again that more than pharmacological intervention, this is the lifestyle modification which is going to be precious. I'm going to talk on the prescribing exercise in type 2 diabetes mellitus. At the outset, I must admit that this topic, I have been inspired by Dr. N.K. Singh's speech on demystifying diabetes, which he did in CCDSI. But my topic is slightly different. My topic is not going into the details of pathophysiology and all, but it is on the practicality of what exercise we should be giving, we should be prescribing to the patient. Intricacies we have discussed time and again, and there are topics available which have justified the role of exercise. But what exercise? Because in all the conferences, now we talk about lifestyle modification. We say you do exercise for 1 hour, but we don't specify what type of exercise they have to do. Physical activity includes all movement that increases energy use. That is very important. But exercise is a planned structural physical activity to achieve a certain goal. For achieving a metabolic goal, the adoption and maintenance of physical activity are critical foci for blood glucose management and overall health in individuals with diabetes and pre-diabetes. Recommendations and precautions vary depending on individual characteristics and health status, and one size doesn't fit all. This is the diabetic triad which all of us will agree to. We have to depend on these 3 pillars if we have to treat the diabetes well. Diet, exercise, medications, and monitoring glucose is the central theme. Friends, exercise is the best insulin sensitizer on the market. It is the best insulin sensitizer, better than any medication we currently have. I will directly come to the physiology during exercise. During the first few minutes of exercise, glycogen in the muscle is broken down anaerobically. First few minutes. After 5 to 10 minutes, yes.
Your slides are not visible.
Visible, it is visible.
Is visible? Visible?
Yeah.
Then my computer
I'm
has
seeing
to-
it.
It is clearly visible.
Yeah.
Yeah, visible.
Should I proceed, sir?
Yeah.
So during the first few minutes of exercise, glycogen in the muscle is broken down anaerobically. And after 5 to 10 minutes of activity, muscle glycogen breakdown decreases. Glucose is broken down in liver now, and it is released into bloodstream and then taken up by muscles as fuel. This glucose becomes the major source of fuel, which we know by the term hepatic glycogenolysis. And what happens after 20 minutes or more? The muscle's glycogen stores are now depleted. Blood glucose is now maintained by hepatic glycogenolysis and triglycerides that are broken down from the adipose tissue. As exercise continues, fat breaks down to free fatty acids and is used as a source of fuel for the muscle through the process of hepatic gluconeogenesis rather than hepatic glycogenolysis. So how it is graded? Before we know how it is graded, metabolic equivalent is the term which we should know. This is the amount of energy expended during exercise relative to energy expenditure during rest. Energy expended exercise versus energy expended during rest. So it is energy expended during rest is considered 1 metabolic equivalent, which is equivalent to 3.5 ml of oxygen per kg per minute, which is equivalent to 1 kilocalorie per kg per hour. So we can classify physical activity intensity in MET, light exercise less than 3 MET, moderate 3 to 6 MET, vigorous above 6 MET. And how we do grading of exercise? I will come to the most popular and easily applicable method. Maximum heart rate is 220 minus age. Suppose my age is 60, then 220 minus 60 will be 160. 160 will be considered the maximum heart rate. And how will you calculate low intensity? 40 to 50% of maximum heart rate. That is 40 to 50% of 160. And In practical world, when we cannot count the heart rate and all, then how you can do it? One can talk and sing during exercise without getting breathless. If we are walking and we can easily talk with our colleagues and we can sing comfortably well, then this is of low intensity exercise. What is moderate intensity? Moderate intensity is 50 to 70% of maximum heart rate. People can chat but can't sing comfortably. And high intensity will be where between 70 to 85% of maximum heart rate, and we can barely talk with each other. So the role of physical activity, we all know. I'm just going to summarize. Improves overall blood glucose control, glycosylated hemoglobin in type 2 diabetes. Improves insulin sensitivity, lowers insulin requirement, often leading to reduced doses of insulin, or we can reduce the number of oral hypoglycemic agents. For the attainment and maintenance of ideal body weight, reduction of coronary risk factors, favorable changes in body composition, the body fat is decreased, weight is decreased, and there is increase in muscle mass, and there is reduction in the overall cardiovascular and mortality, cardiovascular and overall mortality. So basically, the types of exercise are aerobic exercise, resistance exercise. Other exercise which should be known to us is flexibility and balance exercise. This is the calories burned in 45 minutes. This is available in all textbooks over the net. I'm not going into details of it. Now, aerobic exercise are those exercises which where energy expenditure is possible through oxygen, like walking, cycling, jogging, and swimming. This is the moderate intensity exercise which can be funded by oxygen. Now, resistance exercise is the strength training, the exercise which happens with the body weights and weight machines, and sometimes by the body weight. The strength training, here the energy cannot be provided by the oxygen. That is why this is known as anaerobic exercise also. What are the benefits of this aerobic exercise? The increases mitochondrial density, insulin sensitivity, oxidative enzymes, improves compliance, reactivity of blood vessels, lung function, immune function, and cardiac output is improved, and there is substantial reduction of cardiovascular and overall mortality. In type 1 diabetes, cardiovascular fitness, lipid lowering is there, and in type 2 diabetes mellitus, there is overall reduction in glycosylated hemoglobin, triglyceride, blood pressure, and insulin resistance level. Now, what are the benefits of resistance exercise? Resistance exercise is more effective in improving number and function of GLUT4, the glucose transporter 4, which is very important in reducing the level of blood glucose, and blood glucose goes into the muscles. Now, muscle hypertrophy, improved strength, and better physical function. Better tolerability because it is intermittent in nature. Improves mental health and bone mineral density, and more effective in preventing and slowing sarcopenia. I will come back to the first point which I talked, that it is more effective in improving functions of GLUT4. And by in this regard, I want to emphasize that exercise decreases blood sugar level even out of this insulin action also. So extra insulin action, even if the insulin resistance is present, the glucose level can be decreased by the contraction mediated glucose uptake. So that is a wonderful point to be noted, which is there with the aerobic exercise also, and anaerobic or resistance exercise also. This is more prominent with resistance exercise. Flexibility exercise improve range of motion around the joints. Balance exercise benefits gait and prevent falls. Activities like Tai Chi and yoga combine flexibility, balance, and resistance activities. What is the recommendations for reduced sedentary time? All adults, and particularly those with type 2 diabetes, should decrease the amount of time spent in daily sedentary behavior.
Friends, I want to emphasize at this point of time that ADA recommends that prolonged sitting should be interrupted with bouts of light activity every 30 minutes for blood glucose benefits, at least in adults with type 2 diabetes mellitus. So this is after the recommendation of exercise which we are recommending, that is there. But 8 hours of sitting, like our bank colleagues do, like most of our colleagues also do, glued to the chair, that is very much harmful. So above 2 recommendations are additional to and not a replacement for increased structure exercise and incidental movement. Friends, pre-exercise assessment is very, very important. As I told at the outset, that one size doesn't fit all. You just can't say one exercise prescription for all. So we have to assess conditions that predispose to injury before prescribing an exercise regimen. Neuropathy, autonomic and peripheral. Retinopathy, coronary artery disease, a resting ECG and possibly exercise stress test must be done. Peripheral arterial disease. This pre-exercise assessment is very much important because we often come across cases where celebrities, even celebrities, are dying during exercise. You just remember the incidences of Puneet Rajkumar, Siddharth Shukla, or Brahmo Misra, TV and the mega stars of silver screen. So this is very important, how much exercise to do. Exercise should be done according to FIT principle, F-I-T-T. F for frequency, exercise 4 to 6 times a week. Intensity, 30 to 40 minutes of exercise at 50 to 60% of target heart rate. And type is that safe exercises are recommended. Time, morning is supposed to be the ideal time, though there are papers which are suggesting that we may have the muscular strength most in the afternoon, and afternoon exercise may be more helpful, but we are awaiting the data. Aerobic exercise, start by walking at comfortable pace for as little as 5 to 15 minutes at a time. Warm up and cool down are very much important. The major mistake one person does while doing exercise is neglecting warm up and cool down. It is always suggested that gradually progress over 12 weeks to 50 minutes per session, including warm up and cool down of brisk walking. Alternately, shorter exercise sessions in the course of the day. Should be done. 10 minutes 3 times a day after meals can also be useful. In this regard, I want to say that if a person doesn't have much of a time, he is a very busy person. If a person is very busy, then instead of doing 30 minutes, if he breaks into 10 minutes into 3 times, then it can be as beneficial to him. Resistance exercise, choose 6 to 8 exercises targeting the major muscle group, arms, chest, back, legs, and abdomen. In this regard, I will say that going for a specific muscle takes a lot of time, and doing those movements which involve a lot of muscles, the composite ones, they may be more helpful. Gradually increasing the resistance until you can perform only 3 sets of 8 to 12 repetitions for each exercise with 1 to 2 minutes of rest between the sets. When beginning resistance exercise, best to receive initial instruction and periodic supervision by qualified exercise specialists to maximize benefits and minimize risk of injury. Interval exercise training has come into being for its better benefits. This is exercise performed in intervals, alternating between high intensity, low intensity, and they can shorten total exercise duration, increase fitness gains, increase variety also. For example, try alternating between 3 minutes of faster walking, 3 minutes of slower walking. Now I will talk about this high intensity interval training. There is a lot of talk going on the reversal of diabetes. I also believe, as Dr. Hemshankar Sharma sir told that reversal is not possible. Well, it is not possible, but in certain cases, when the diabetics are less than 5 years of duration and the patient is highly motivated and there are no comorbidities and other things are present, favorable points are there, high intensity interval training is a good option. This is a form of interval training, a cardiovascular exercise strategy, in which there is alternate intense burst of high intensity exercise with medium intensity exercise for recovery. You do high intense burst of exercise for short time, and then you go not to the rest level, but to the medium intensity exercise. For example, alternate between 30 seconds at very high intensity and next 90 seconds at low intensity. The beautiful point is there is considerable increase in number and quality of the mitochondria, which are the powerhouse. So you get more conversion of ATP from the glucose, and you are powered to do more difficult works, more oxidative capacity of the muscle, and it slows down sarcopenia, that is the loss of muscles. Friends, we know that in type 2 diabetes mellitus, particularly with age, we all lose muscles, but with type 2 diabetes, we lose it more often and considerably more. And here, this high intensity interval training will slow down sarcopenia, more cardiovascular fitness, and more effective lowering of insulin resistance, resulting in better mental function and sharpness. So ADA recommends that pre-exercise medical clearance is generally unnecessary for asymptomatic individual prior to beginning low or moderate intensity physical activity, not exceeding the demands of brisk walking or everyday living. For the uninitiated patient, we can safely advise to go for a walk or so. Most adults with diabetes should engage in 150-minute or more of moderate to vigorous intensity exercise weekly, spread over at least 3 days per week, with no more than 2 consecutive days without activity. That all of us know. Shorter duration of vigorous intensity exercise is as good. Either 150 minutes of moderate intensity or 75 minutes of this per day of this vigorous intensity is equivalent. 150 minutes is in a week or 75 minutes in a week. Children and adolescents with type 1 or type 2 diabetes should engage in 60 minutes per day or more of moderate or vigorous intensity aerobic activity with vigorous muscle strengthening and bone strengthening activities included at least 3 days per week. Adults with diabetes should engage in 2 to 3 sessions per week of resistance exercise on non-consecutive days. Flexibility training and balance training are recommended 2 to 3 times a week for older adults with diabetes. Yoga, Tai Chi may be included based on individual preferences. Individuals with diabetes or pre-diabetes are encouraged to increase their total daily incidental physical activity to gain additional health benefits. Throughout the day along, one should remain active. If there is knock on the door, you rush, you open the door, you take the water yourself instead of taking help from someone. So remaining active is very important throughout the day. To gain more health benefits from physical activity program, participation in supervised program is recommended over non-supervised programs. In type 1 diabetes mellitus, the issue is more complicated. Insulin resistance here is not a major issue, and with the glycemic control is very variable, more hypoglycemia, so you have to be more aware. Decrease insulin dose prior to exercise for the short sessions. In the long sessions, we have to monitor glucose monitoring, and frequent carbohydrate feed should be nearby. In the gestational diabetes, regular physical activity should be done prior to or during pregnancy, and they should engage in 20 to 30 minutes of moderate intensity exercise. Vigorous exercise should be avoided because of the obvious reasons. So creating a healthy carb strategy, eating small meals throughout the day, staying active throughout pregnancy, monitoring blood glucose levels, sharing details with consultant doctors and taking advice. This is the walking program, not going into details. In peripheral and autonomic neuropathy, recommended is non-weight bearing activities, swimming, bicycling, chair and arm exercise. Contraindicated are treadmill, prolonged walking, jogging, and a step exercise. In nephropathy, low to moderate intensity exercise is recommended. High intensity forms of exercise may precipitate kidney failure more. In diabetic retinopathy, low impact cardiovascular conditioning such as swimming, walking, low impact aerobics, stationary cycling, endurance exercise. And contraindicated are strenuous activity, pounding or jarring, such as weightlifting, jogging, high impact aerobics, and racket sports. Useful tips are a diabetic should carry an identification card, check feet before you walk, check good footwear, light clothing, drink a lot of water, and don't exercise during hot seasons. Hypoglycemia, despite so many issues, remains one of the major causes of death, where because of lack of 15 to 20 grams of carbohydrate, patient loses life. So we have to be aware of this. It will most likely occur if the patient is taking insulin or diabetic pill, skips a meal, exercise for a long time, exercises strenuously. If it occurs, what can be done? Patient must eat a snack before exercise or adjust the medication dose. Remember, patients should always carry a source of carbohydrate, preferably glucose, with him. Snacking to prevent hypoglycemia. I'm not going into details. And physical activity lowers blood glucose in type 2 diabetes mellitus. Muscle cells become more sensitive, keeps liver from producing too much glucose, builds more muscle. We lose weight and keep it off. And this is from one of the studies, response to 100 grams of glucose in mild type 2 diabetes after 15 months of training, how the glucose tolerance test has improved. The red one is before training, yellow one is after training. Now, diabetes mellitus may be a chronic disease, relentlessly progressive disease, but we have got celebrities with this. Thomas Alva Edison, Mario Puzo, Kamal Hassan, Sonal Kapoor, Nick Jonas, etc. Now, this is Billie Jean King, so many times Wimbledon and one of the tennis greats. Determination makes a champion. Wasim Akram says, I won't let diabetes pull me out. So, respected seniors, dear friends, it is the take-home message is all diabetics should be motivated and educated about planning out exercise, because it will save from the complications, from the money, it will increase the life expectancy and load on the society. Exercise is unfortunately an invaluable drug. It is $1 million drug which is seldom used. We should motivate people to accept exercise as a way of life since early school days. There was a brilliant talk by Dr. Patni on pre-diabetes. I will emphasize on the point that we should motivate our people from early childhood, from the early school days, to accept exercise, and of course, the dietary education also. And if we can achieve this, this may perhaps help us fight the tsunami of type 2 diabetes mellitus. RSSDI can advise the government. We have great diabetologists like Ajay sir and Dr. Sudhir Bhandari sir, who can advise the government, who can influence the RSSDI decision committee to make exercise an integral part of school curriculum. I remember during our school days, we would have Scout and NCC curriculums, but unfortunately these days I'm seeing this is missing. This should be made integral part of the school curriculum, and we should spread the awareness if we want to lessen the socio-economic burden and remove our tag of diabetes capital of the world. Thank you.
I think this was a really brilliant talk by Dr. Jha and very informative. And he has dealt, I think, all the aspects of the diabetes exercise as a drug, which should be prescribed. I think Dr. Manish, I will take comments from you also. But I think I remember at one airport, Dr. Ajay Kumar was with me, and उन्होंने कहा कि मेरे रात में हम 2 बजे सोए या 3 बजे सोए, सुबह उठ के आधा घंटा ट्रेडमिल पे चलते ही चलते हैं. तो एक्चुअली साइंस इज वेरी obvious, but this art, why Dr. Ajay Kumar, when even at this age, I think
सर की जवानी का राज खुल गया.
हाँ, जवानी का राज उनका खोलना जरूरी है. तो ये मोटिवेशन हम अपने पेशेंट को कैसे दें, ये बड़ा इंपॉर्टेंट है. मुझे याद है एडीए कोविड के पहले जब हम लोग गए थे तो उसमें 1 घंटे का एक टॉक था एक लेडी का, और उसने कहा कि जब एक्सरसाइज से आपने दिखाया कि इतना फायदा है तो फिर लोग चलते क्यों नहीं है. तो उन्होंने इसने दिखाया कि हम एक्सरसाइज को जिस तरह की हम दवा लिखते हैं, प्रिस्क्रिप्शन उसने फॉर्मुलेट करके दिखाया, और हम लोग बोला कि एक्सरसाइज को आप अपने पेशेंट को इस तरह से बताओ कि आज एक्सरसाइज करोगे तो ब्लड शुगर घटेगा, बाद में तुमको बहुत फायदा होगा, हार्ट ठीक रहेगा, किडनी ठीक रहेगा, स्ट्रोक नहीं होगा. ये सब मत बताओ, बताओ कि आज का एक्सरसाइज करो और अभी का भी फायदा लो, क्योंकि एक्सरसाइज करने के बाद ही फायदा होता है. नंबर 1 क्वेश्चन ये है, एक बड़ी इंपॉर्टेंट छोटी सी मैं घटना आपको बता रहा हूँ कि एक एक्सरसाइज, जब मेरे पास कोई भी नया पेशेंट आता है टाइप 2 डायबिटीज या जो भी, तो उसको 5 मिनट हम एक्सरसाइज जरूर समझाते हैं. तो मैंने बोला कि आप रोज कितना घूमते हैं. बोला सर हम तो घूमते ही रहते हैं, 2 घंटा रोज घूमते हैं. तो हमको लगा जब 2 घंटा आप घूमते हैं तो फिर तो डायबिटीज आपको होना नहीं चाहिए, तो आप क्या करते हैं, कैसे घूमते हैं. बोला सर हम तो बाइक पे घूमते हैं सर 2 घंटा, एक से खूब मोटरसाइकिल चलाते हैं. तो ये यहाँ पे प्रॉब्लम है, जहाँ की हमको बताना है पेशेंट को कि किस तरह से घूमना है, कैसे घूमना है. और आजकल बेसिकली बहुत से पेशेंट्स हमारे आते हैं जिनके जॉइंट में प्रॉब्लम है, न्यूरोपैथी है, तो उसमें किस तरह से रेसिस्टेंस एक्सरसाइज करनी है, क्योंकि साइंस इज क्लियरली शोइंग दैट इफ यू कंबाइन बोथ द एरोबिक्स एंड द रेसिस्टेंस एक्सरसाइज, द इंसुलिन रेसिस्टेंस, the insulin sensitivity, that increases very much, and even the reduction of the HbA1c is quite impressive, more than the drugs. I have got a studies, and if we had one survey in Jharkhand where I think only 20% of our diabetic patients walk, only 20%. I don't know what is your experience, Dr. Manish and Dr. Ajay Kumar. I will take comments from them. So I think these points, the art of the exercise also, when you are prescribing the exercise, this art to be discussed, and you must have some time, 5 to 10 minutes at least for the initial new diabetic cases, where we can motivate, and only you are motivating once, it is not enough. I think in every visit you should motivate, you should ask whether you walk or not, or exercise or not. So Dr. Ajay Kumar, I think I will definitely take how to motivate our patients, and what motivates you to do so much treadmill at this age?
I think the answer is very simple. Sudhir actually mentioned and alluded to this issue, that at the government level or societal level, we have to make awareness about the benefits of exercise. And in that context, I think why I do it is very simple to understand, that right since my childhood, I was a sportsman. Now, when you give advice to somebody, what is the level of reception of an individual differs depending upon the age of the person sitting in front of you. And it has been very scientifically studied that the most impressionable age is between 10 to 16 years of age. And that takes us to a very simple logical conclusion, that if we have to make exercise as a national habit, it has to be the school. If the government of India, state governments, people in general emphasize the importance of exercise during school days of any child, then I'm sure this is going to take a very big turn. And I'm very happy, because I run a number of schools in Bihar, the new national education policy has put a lot of emphasis on this, inculcating the element of exercise into the day-to-day school education. And I'm sure great. If we diligently follow this, this will usher in a new era in health of the country. Thank you.
Thank you. Dr. Manish, your comment?
Sir, this exercise is really very much important for the diabetic and the pre-diabetic state. As it is well said by Dr.S.C.Jha sir, and elaborated a very beautiful section regarding each and every person of diabetes, that what exercise to be done in each person. Dr. Ajay sir has already told a beautiful study quoted about the Roy and Taylor, that exercise and diet is the major, may play the major role for the prevention of diabetes, not even for the prevention of diabetes, for the curing of diabetes. But what we feel that is very much difficult to make the patient understand that what kind of exercise is important for him. Suppose a patient comes, he doesn't want to take pill, and what he will ask that we will all manage for after doing this exercise and all. That particular time is very much difficult to make us the patient understand. So Dr. Jha sir has already quoted all the beautiful section about the diabetes. So this is all.
Dr. Singh, may I come in?
Yes, I welcome Dr. Vikas Bhattacharya sir from Governing Council.
I was just thinking to invite you, sir, Dr. Vikas sir, for your comment.
Welcome, sir.
Good evening, sir.
Thank you. Thank you, Dr. Jha, for a wonderful comprehensive presentation. We talk.
Thank you, sir.
We hear very less presentation on exercise. It is so important. And you said very correctly, you know, exercise is important for preserving a very important organ, muscle mass. It is so important for glucose disposal. We talk about beta cell preservation. Muscle mass has to be preserved, and exercise is one of the part. We can do it with that. And you talked very nicely about GLUT4 translocation. Without insulin, that can be done. So it's a great sensitizer, no way. But one thing only, you know, exercise is good, but then non-exercise activities are equally important. They're also important, and especially in the diabetes people, because you increase in calorie loss by that. So non-exercise activities, many people do go to gym, and when they come back, they don't do anything. Pani lao, so gaya, pani lao, pani nahi laenge. So we should stay on non-exercise activities, and hypoglycemia, of course, irregular exercise must not be there. Suddenly one day, 1 hour, and then at night, you know, he landed up in bad hypoglycemia. We talked about that also. So thank you so much. Wonderful presentation.
Thank you, sir. Thank you, sir.
Dr. Hemsankar has done a marvelous job by just, I think, lifestyle modifications. So we must listen Dr. Hemsankar Sharma for tips of
Yes, sir.
Yeah.
Yes, sir.
Only few things I would say. As far as exercise is concerned, in the current perspective, we know everything about it. And I think the first talks and the generation was done by none else than Dr. N.K.Singh, who moved with exercises for the first time. Well presented the articles also, and delivered many talks. Exercising with the dogs. This was one very important presentation by Dr. N.K.Singh.
Slide was also very attractive, sir.
Yeah, that was also presented internationally. And not only that, resistance exercises, which were initial days, that doing a bulwarker and all that is a bad exercise, has been proven wrong. And now we know that resistance exercises are to cut down the resistance of insulin. In simple words. So the Charvak Ukti of Charai yani go on walking is a very important issue. The two issues which are very important, that as a doctor and a physician, as a diabetologist or as a general physician, we give much less time in educating our patients. That is a very bad aspect, and we should all have an introspection that we should limit our examining the patients in numbers. We should not discuss that how many patients we examined today. We should discuss how many patients we have examined properly and thoroughly today, and how many of them we have educated. So we should give education to all the patients for at least 2 to 3 minutes, and that will be improving. And that will be the right now the one question which one point which was raised by N.K. Singh, that you ask all the patients, you write on your prescription all diabetics, all hypertensives, all CADs. You write number 1, exercise this minute, this time. That should be the first prescription of lifestyle modification. We don't write it. What do we write? In the left-hand corner, lower down, you will write either a consult physiotherapist or consult dietitians or exercises. But hardly ever we write it as number 1 drug. And everybody of us will be saying that exercise should be the number 1 drug. Food should be the number 2 drug. Good sleep should be the number 3 drug. And then doing all the drugs and all that. And we all know that all the Taylor's articles and Dr. Ajay Kumar's all comments in the initial time that we have to increase our exercises, lifestyle modification to cut down the drugs so that as to fight with all, we go together with our all old system of Ayurveda. That is very, very important. Thank you.
Thank you, Dr. Hemshankar ji. Excellent tips.
Can I have
think,
a question?
Yeah,
Can I
any
have a
question? Yeah, Dr.
Yes,
B.K.Singh.
yes. My question is that 2 questions are with Dr.S.C.Jha, sir. One question is, which is important, whether decreasing weight is important or the exercise is important? First question is this. And second
decreasing weight and
exercise. Which one is important?
Achha, achha. Both are important. Both are important, and most important is while we reduce weight, where we are reducing weight, that is also very much important, because we are a population, we are thin obese. We have got a lot of visceral obesity. So I think both are important.
Yeah, I think for the reduction of weight, I think that dietary modifications work much better. But many patients in our day-to-day clinical practice, we see that even after doing proper exercise, there is no reduction in the weight. But that doesn't mean that the exercise is not working. It is working in very different ways and in different things. Suppose a patient is coming to you and say a young patient, oh, I have got some erectile dysfunction problem, what to do? Exercise is a different issue now coming in a big way in diabetes also. By doing exercise, you can improve the endothelial health. And many times I have seen that this problem of erectile dysfunction only improves with proper exercise. Apart from that, I would also like to give some impression that lots of excellent work on the pranayama, on the basically this is going on the USA. I have some interactions with some such researchers, and they are showing that by doing this pranayama, lots of compressive things are happening with this pancreas and improving the blood supply. And I think in 2 or 3 years, excellent data will be out. So apart from that, yoga has very important role. So I think many times people will ask you, okay, which time? Don't say that it is only morning time. Any time you say, even the evening time, after walking, different type of exercise. So there is also a separate issue now. This and I am really happy, Dr. Jha, you touch about the heat. Heat is very, very important.
Yes,
this
sir.
is emerging as one of the best modality these days, where time restraint is there. So by doing, suppose you 1 minute of you showed that 30 seconds of intense running or walking, whatever it may be, and then followed by a bit of sedentary movement that known as heat. I think YouTube is full of many videos you can learn from that. And I really say my patients go, if there is any problem, just go and type the home exercise, resistance exercise. Dr. Vikas was telling that sarcopenia, or this will be not prevented by doing aerobic exercise. Remember?
Yes, sir. Yes, sir.
It is only you can improve it by doing resistance exercise. So at least 3 times in a week, doing a resistance exercise is very, very important. And then other days you can
Sir,
do the
I have a contrary question. Since we are talking on exercise, very important for everyone to understand. As we are, many of the patients are suffering from the Swamiji syndrome. And in our clinical practice, we are seeing a lot of patients who are having, in fact, majority of them is suffering from neuropathy, retinopathy. And morning, they will go to the park, and I know what the rush they have over there. So I think no talk is complete once we don't discuss about the type of exercise which we need to suggest to the people who have a neuropathy and retinopathy, because many of them will be landing up with a lot of foot ulcer, and arthritis is one which is in huge rise in diabetic population because of different exercise and yoga posture. So any take on that, S.C.Jha, sir?
Yes, Subhash, this is a wonderful question and a very practical question. There comes the limitation of aerobic exercise, particularly high intensity exercise. And there are certain resistance exercise which can be done when you are not able to do because of, say, osteoarthritis of the knee. You are not able to do the aerobic exercise. So you have to intelligently know that in the case of retinopathy or nephropathy, high intensity exercise should be avoided. And we have to locate certain situations where aerobic exercises cannot be done, but resistance exercise can be done. And as far as the talking Swamiji syndrome is concerned, well, there are studies going on which are going to prove that yogic exercises are going to be a metabolic regulator. But as of now, I would like to have opinion of icons, Dr. N.K.Singh, Ajay Kumar, and other Vikas Bhattacharya, sir. As far as the present thing is concerned, this is supplementary to the other two main group of exercise, resistance exercise on this. And resistance exercise has got one wonderful thing with it, that it is independent of this insulin mechanism. GLUT4 mechanism gives it, even when the insulin resistance is of the highest order, this contraction during resistance exercises is going to force glucose into the cell. That is very much important.
The resistance exercise.
And as thank you, Dr. N.K. Singh, for congratulating me on including HIIT. No talk on exercise will be complete without high intensity interval training. But recently, people are talking about how it improves the number and function of mitochondria. It is increasing the number of mitochondria. It is improving the number of and more molecules of glucose are being converted into ATP. And ATP means what? This, your exercising capacity is going to increase more and more.
Yeah, excellent comment, Dr. Jha. I think Dr. Subhash has valid points, and I was just talking about that. That in osteoarthritis, in neuropathy, definitely there is a role of the exercise prescription. You write down which exercise you should do after assessment. So that is a different part of thing. Otherwise, HIIT is very important for a certain type of patients. But definitely some people will not like this HIIT. Some people will not like resistance. You have to give some alternative. And there are lots of machines available in the market. Many people are eager to buy that, and by that you can do the resistance exercise. Otherwise, apart from that, many pushing, push up, and many other things you can do, even with the hands.
Sir, there is a study going on in Mayo Clinic that even above the age of 65, high intensity interval training is going to perhaps reverse the aging process, may have effect on that. But having said that, at the age of 65, we have got a lot of comorbidities. Cardiac assessment.
Dr. Jha, don't give me a gloomy picture. Dr. Ajay Kumar is here. So you get some inspiration from him. So 60 is nothing, 70 is nothing.
Over to
Ajay, sir.
Just one quick point.
Sir, before I allow respected Ajay sir to say on this, Ajay sir is the fittest person we can have around in that is. But when I'm talking about those people who have got the comorbidities, those we have to consider. Yes, sir. Ajay sir.
I just want to give just one quick comment to Subhash's question. Sudhir, you have already shown that slide that people who have neuropathy, etc., what kind of aerobic exercises they should do or what they should not do. You have that slide.
Yes, sir. Yes, sir.
I think you have already answered that question, that they should be
very clearly.
doing patients with autonomic neuropathy should not be doing treadmill, etc. You have very nice slide on that. I just wanted to mention about that.
I have a
Thank you, sir.
I will ask a comment from you, Dr. Jha. 10 minutes post-meal walk. What's your recommendation? Particularly postprandial hyperglycemia.
Previously, post-meal exercise was not advocated. But recently, some papers have come up
No, ADA has given.
There is a recommendation in ADA.
ADA has already given a recommendation, so there is no doubt about it.
And in case of gestational diabetes mellitus, we are saying the patient that after half an hour of eating, she can go for a 15 minutes walk, because it is very difficult for a pregnant lady to do 1 hour at one sitting. So 3 meals she is having, and post meal she can have 15 minutes walk.
So this is definitely Dr. Patni. The ADA has given a clear-cut instruction for that. So
that need to be included in the dietary exercise prescription. And another way, if you, with your permission, Dr. Singh, it's a very odd question. Do we have any difference in exercise prescription for pre-diabetes and diabetes?
It depends again. Suppose a pre-diabetes can also have some comorbidity. Suppose a pre-diabetes has got some osteoarthritis or neuropathy.
That is same.
The same thing. So
recommendation is almost same.
Depends on the after the assessment of the patient, maybe pre-diabetes or diabetic. Even many diabetics are so fit, so they can run and everything can be.
So the bottom line is there is no difference for the exercise prescription for pre-diabetes and diabetes.
Yeah, definitely. I think I say that even at age of 60 and 70, you prescribe the things if he can do or she can do. So there is no harm in prescribing a 70 years or 75 years if for running also, if it is possible.
There only one comment I am allowed.
Yeah, sure.
Please, sir.
The comment is that the question was by Dr. B.K. Singh. Which one to be treated first, the weight reduction or the exercise? Can I ask B.K. which tire to be repaired, the first one of the car or the back one of the car? Otherwise, your car is not going to move.
One of the article I have.
No, I'm not going into the scientific aspect. I'm going to more scientific aspect.
Sir, there was always a question is being asked, diet important or exercise important? It is like a question which is put to a child कि मम्मी ज्यादा प्यार करती है कि पापा ज्यादा प्यार करती है?
Correct.
One thing I want to emphasize here, sir, कि in our early days, मेरे दादाजी कहते थे कि नाइट में खाना खाने के बाद 15 मिनट चलो।
वज्रासन करो नहीं बताया। हाँ? वज्रासन करो नहीं बताया।
हाँ, ब्रह्म मुहूर्त में आप उठ करके अपना एक्सरसाइज कीजिए। एंड लंच के बाद कभी भी मत चलिए। That is the 3 things.
Dr. B.K. Singh.
One more talk we have.
Yes, so we don't have time. Dr.Sudhir.
I'll request S.C.Jha sir to introduce the chairperson for the next.
So I will end here. With all compliments to Bihar RSSDI and especially Dr.Sudhir Jha and Dr.Subhash. Yeah, thank you very much for inviting.
Thank you.
Thank you, sirs. And now I will ask chairpersons for the third talk, Dr. R.R. Verma and Dr. Naveen Kumar, to take over and introduce our speaker, Dr. Amit Kumar Das, on a very vital topic, the dietary modification in diabetes mellitus.
Am I audible?
Yes.
Yes, yeah. Thank you, sir. Good evening, everyone. As the Dr. Patni sir said, the prevalence of pre-diabetes is increasing worldwide and India also. And Dr. Jha sir emphasizes on the topic exercise. So diabetes is one of the biggest global health problem right now, and the diabetes is a lifestyle disease. We know the lifestyle disease, and there are 4 major pillars, as Dr. Jha sir said, that there are 4 major pillars in the diabetes control. One is diet, other is exercise, and third one is the drugs we are taking, and the fourth one is the regular monitoring of the blood glucose. So the nutrition and the physical activities are the important parts of a healthy lifestyle. When we have diabetes, along with the other benefits, following a healthy meal plan or being active can help you keep your blood glucose level in the target range. To manage our blood glucose, we need to balance what we eat, when we eat, and how much to eat. So the diabetes medicine, if you are taking along with the diet and exercise, so it is important to how we plan our diet in the particularly in the diabetic patient. So today we have Dr. Amit Kumar Das, who is well-known physician and diabetologist of Bihar. He will talk on the role of the diet, particularly in the diabetes. So handed over to the Dr. Amit Kumar Das.
Thank you, sir. Thank you for the nice words. I'd request the host to allow to share my screen, please. I'm greatly indebted to the scientific chairman of RSSDI Bihar this year, Dr.Sudhir Jha sir, for including me in this scientific webinar. And I would also request the host again to allow me to share my screen.
Arjunji and Vimleshji, kindly allow.
Mute.
Sir, you've shared the screen. You've allowed to share it.
Yeah. Thank you, sir. Thank you, chairpersons, for introducing me, and deep felt gratitude to the guest of honor, Dr. Ajay Kumar sir, to the chief guest, Dr. Bhandari, and to the all galaxy of diabetes specialists in Bihar, Jharkhand, and all across the country for having participated in this webinar. The show has begun on a very high note, and the controversy has also set in. A child is often asked, who do you like most, or whom do you love most, your mummy or your papa, as Dr. Jha said, and the answer has always been perplexing for the child. Similarly, as introduced by the chairperson, there are 4 pillars, and one of the most important pillar is diet in diabetes, and I'm going to highlight some of the important points in diabetes, diet in diabetes, and this would be very basics to some of the questions which have been put during the show of role of diabetes in role of diet in reversal of diabetes. So these are my credentials, and I am deeply obliged to the organizers of this event to include me. So if we talk of medical nutrition therapy or diet in diabetes, this is the most challenging part. Every person who drops into a clinic of diabetes specialist, the last question or the first question that he has in mind is what to eat. बैंगन खा सकते हैं कि नहीं, कद्दू खा सकते हैं कि नहीं, एप्पल खा सकते हैं कि नहीं. So these are some of the very basic questions which run through the minds of a diabetes patient, and these are at times become very challenging to answer. But we all understand that a medical nutrition therapy, which is one of the pillars of management of diabetes, has been documented to decrease HbA1c from a significantly important numbers of 0.5 to 2.6% HbA1c, average 1 to 2%, which is almost equal to most of the potent anti-diabetics, and at times better than some of the lesser potent anti-diabetics. So MNT, or medical nutrition therapy, is one of the key factors in managing diabetes, and if MNT is not taken care of, possibly glycemic control is not going to be achieved. So what is the objectives of MNT? To prevent complications, to treat obesity, to treat dyslipidemia and other comorbidities, and definitely to consider the person's nutritional needs while taking into account the personal and cultural preferences and lifestyle issues of that particular person. And definitely to respect the individual's rights, decisions, and willingness to change. Now, if a person who is a vegetarian, you cannot force him to become a non-vegetarian, and if a person who is a non-vegetarian, you cannot force him to become a vegetarian. So we need to understand the values and the preferences of the particular individual before we prescribe a medical nutrition therapy, and while doing so, to optimize the quality of treatment that we are going to provide to the patients. And what is the principle? The principle is to provide adequate nutrition, adequate nutrients for health, growth, and development. depending upon the age of the person at what the patient enters into the care. To maintain, by providing a proper nutritional prescription, you can maintain the social and psychological well-being of that particular patient. To reduce the symptoms of diabetes, to achieve and sustain an acceptable body weight, to prevent, delay, and treat complications, and to integrate those diet into its activities and other pharmacological therapy. So MNT becomes one of the integral part of management of type 2 diabetes. And while before we prescribe a medical nutrition therapy, we need to have a prior assessment. So the prior assessment would include a history and a physical examination, and a history would assess the patient's psychological, social, and physical status, his lifestyle, his culture, his socioeconomic status, the person's age, his oral health, his other comorbid conditions, his food preferences, eating habits, and his willingness to change the food if it's required, his clinical assessment prior to a medical nutrition therapy, his anthropometric measures, and his assessment for nutritional state by a dietary call and a nutritional history. So these are some of the prior assessment of MNTs. And if a person who enters into the care is a child, we must aim to maintain appropriate weight gain, to maintain his, to achieve his, growth and developmental milestone through nutritional role, and to, if the person is obese, if the child is obese, weight loss, if it's helpful when the person might be having a type 2 diabetes, children might be having type 2 diabetes. If the person is elderly, so this is a very special situation and a very often, met situation in real life. You need to understand the concomitant condition, his age-related physiological changes such as the loss of teeth, which is very significant, and his family structure of who's going to cook food for that person. A pregnancy is a special situation that in the diabetic clinic, and in pregnancy you need to understand that this particular individual would require a higher calorie intake, and hence a calorie intake should, a prescription should include an increased calorie intake. So optimum growth nutrition that would ensure optimum growth for the fetus, to reduce the risk of diabetes related complications for both the mother and the child, and minimize maternal and infant morbidity and mortality rates through dietary prescription, if any. So we must take into consideration of all these factors before we sit down and write a prescription for diet. And importantly, one size will not fit all. So we need to individualize all our patients, and we need to understand that this is the usual dietary recommendation: a carb of 50 to 60%, a fat of 20 to 35% of the daily calorie intake, a protein to 10 to 20% of the daily calorie intake, which would be amounting to 0.8 gram per kg per day, and a dietary fiber should include 20 grams per 1000 kilocalories in the ratio of 50 to 50. And then we should also consider micronutrients, vitamins, and minerals. So macronutrients, we understand that carbohydrates become the main source of energy for the body. Indians, we all know, are carbohydrate friendly people. So our diet constitutes almost 50 to 60% of the total calorie intake that we take, and this is the most important dietary component which influences blood glucose levels. And then we have simple sugars like glucose, fructose, and we have complex sugars. What is recommended as far as carbohydrate is concerned is the amount and source should be considered when planning meals, and recommended sources mainly from complex carbohydrates like whole wheat, flour, rice, pasta, unrefined cereals like oats, jowar, and bajra should be recommended over the glucose and fructose. Legumes, beans, pulses should be preferred. Potatoes can be recommended. Fruits, vegetables, and milk should be in the diet, in the carbohydrate component of the diet. Now, as far as fats are concerned, this is the most concentrated source of energy, and foods may contain fat naturally or have it added during cooking, and they are energy bundles. 1 gram of fat will give you 9 kilocalories of energy. So what is recommended is that a fat should be of polyunsaturated, mainly up to 10% of total daily energy, and it should also have high monounsaturated fat, which is more than 10%, and should have very low saturated fat, less than 7%. Trans fats, hydrogenated fats should be avoided. So for this is the fat prescription. Now proteins are important building blocks of the body. 1 gram of protein will give you 4 kilocalorie of energy. Proteins provide amino acids. They help to build muscle mass. They have both animal and plant sources. So what is recommended is a 0.8 gram protein per kg body weight per day. 10 to 20% of total energy should come from proteins. Animal protein are often high in fat, especially saturated, so they should be avoided, or their amount should be regulated. Vegetable proteins are having, they are lower in fat, so they should be recommended more. And attention should also be paid to meeting the protein requirements people who are vegetarian or vegan. So we must take into all the aspects while prescribing protein intake. Now, fiber is an important component of our diet. Of high fiber diet is healthy. Mixture of both soluble and insoluble fiber is recommended, which will slow the absorption of glucose, which would reduce the absorption of dietary fats, which would retain water to soften the stools, and that thereby reduce the risk of colon cancer. And of course, constipation can be addressed, and it can also reduce the risk of heart disease. So what is recommended? The recommendation is the amount of fiber for people with diabetes should be 20 grams per 1000 kilocalories, and it should be in the ratio of 50-50 of both soluble and insoluble fiber. So source of insoluble fibers are wheat bran, which is called choker, whole grains, seeds, fruits, and vegetables. And source of soluble fibers are legumes like beans, oat bran, barley, apples, citrus fruit, and potatoes. Vitamins in diet are organic substances which are present in very small amounts in the food, but they are very essential for good health. A balanced meal should contain all necessary vitamins, either fat soluble or water soluble. And we have fortified vitamins, fortified foods which have vitamins in ingredient incorporated into the foods. Now, what is recommended is for the majority of people with diabetes, there is no need for additional vitamin and mineral supplementation when dietary intake is adequate. So we don't need to prescribe a vitamin with all your diabetic anti-diabetic drugs. If the adequate food is ensured, the amount of vitamins and minerals are ensured, there is no need of vitamin prescription in vitamins for in your diabetes prescriptions. Multivitamin supplements are only needed when people are in special circumstances. So a routine vitamin prescription is not recommended. Minerals are again smaller requirements of the body, but they act as important. They have important functions to subserve. They help maintain physiological processes, strengthen skeletal structures, preserve heart, brain functions, and other nervous system. They act as catalysts, and though low levels of minerals are required, but they are very, very important. Like calcium supplements may be desired for elderly people, pregnant and lactating women. Iron may be required in pregnancy in populations where anemia is common. Folic acid supplementation is recommended for prior to and during pregnancy. So this is a special situation, but routinely minerals and trace elements are not to be prescribed regularly. Now let's have few words regarding sodium. Now sodium contents are often very high in our restaurant foods, like foods that we have in our CMEs and meetings. But what is recommended is that we should have a restricted salt intake, especially for people who have comorbid hypertension, heart disease, kidney failure. So targets for sodium intake for age group of 41 to 50, adequate intake would amount to 1500 milligram per day, and the uppermost limit is only 2300 milligram per day. For people who 51 to 70 years, it's again 1300, and maximum is again 2300, and over 70 it's 1200, and maximum again is 2300. So you can just assume that how small quantity of sodium is required for maintenance of our body system. Definitely we take much larger amount of sodium intake. Now, sodium per se in diabetes is not a contraindication, but people who have a comorbid condition like hypertension, heart disease, kidney failures, we need to take care of this sodium intake as well. Alcohol, no, a question not to be discussed in Bihar nowadays, but then as the dictum goes, we need to have few words in alcohol. Adults with diabetes who drink alcohol should do so in moderation, not more than 1 drink per day for adult women, and not more than 2 drinks per day for adults. Now, 1 drink is 30 ml only, my dear friends. Alcohol consumption may place people with diabetes at increased risk for hypoglycemia, especially if taking insulin or insulin secretagogues. And we have seen so many patients who have taken alcohol, have gone into hypoglycemia. They being treated as being unconscious because of alcohol effect, and leading ultimately to unconsciousness, vegetative state, and ultimately death. So alcohol is a dangerous option for people who have diabetes, especially who take frequent amount of alcohol. Frequent amount of alcohol is going to is going to cause a persistent hyperglycemia and is going to derange your sugar controls, and binge alcohol can cause hypoglycemia. So therefore, alcohol should be taken definitely in moderation, and moderation I've already discussed. Artificial sweeteners, no, there are two categories of artificial sweeteners. One is a nutritive and the other is non-nutritive sweeteners, depending upon the amount of calories that they provide people, which is now recommended. What we often understand by sweeteners is non-nutritive sweeteners, and the non-nutritive sweeteners, which are often placed in the market and often asked for, is sucralose, sugar, which is stevia. These are natural sweeteners, and we need to understand that there is a recommended daily allowance of all sweeteners, and this is what is the acceptable daily intake. And if we go beyond these, there are certain agents which can cause devastating effects, especially the ACE sulfam. So these are some of the recommended FDA acceptable daily intakes of artificial sweeteners. Now, we also need to understand that a dietary management can also lead to weight management, and we need to understand that small amount of weight loss, like a 10% of weight loss, can have significant effect on diabetes, not only diabetes, but total metabolic control. So it can decrease insulin requirement, it can reduce diabetes by 50%, diabetes-related deaths by 30 to 40%, total cholesterol reduction by 10%, HbA reduction by 15%, HDL increase by 8%, reduction in triglyceride by 30%, reduction in LDL by 15%, and total cholesterol reduction by 10%, fasting glucose reduction by 30 to 50%, and systolic and diastolic blood pressure reduction by 10 mm of Hg. So this is not to highlight, but just to reverberate that 10% weight loss can have such huge, metabolic advantage. So nutritional education is a must, and we need to educate these patients of the a plate concept of healthy eating plate of a person, where use healthy oils like olive and canola oil, more vegetables in your food, some amount of fruits, whole grains, and a healthy protein. So this is, and then adequate drink water, tea or coffee with little or no sugar. Limit milk or dairy by 1 to 2 servings, and juice by 1 small glass per day. Avoid sugary drinks. So this is the healthy eating plan which you can have on your prescription, either printed or you can just plan for your patient. Now we need to understand that there are certain foods which are red, which should be taken in small amount or should be avoided as far as possible, and there are certain foods which are green, which you can take a good amount of food. So green foods or healthy choices are foods which have low glycemic index foods, high fiber content food, low in fat. Red foods should be avoided as far as possible, like rich in fat, sugars, high glycemic index foods, and low fiber content foods. Yellow foods should be taken in moderation, like high GI index, glycemic index foods, low fiber content, and moderate fats food. So these are some of the options in the same class of agent. So like rice, you can have steamed rice, which is a green zone, but if you start taking biryani or fried rice, that becomes a red zone food. So you should avoid that. So for the similar kind of food material, you can have a green zone, a yellow zone, and a red zone. And what we should teach our patients that green zones are to be taken. Now this becomes more practical and more important when you go for a feast. Especially in Bihar, we have multiple options of food in marriages and other ceremonies and conferences. And normally what we choose is the red zone. We try to choose biryanis more than steamed rice. Now, as far as breads are concerned, you should ask for whole wheat bread rather than going for the lacha parathas and parathas and those stuffed naans and butter naans. So Indian breads like chapati should be preferred over butter naans. Potatoes should be given in yellow zone, French fries and mashed potatoes should be in the red zone. So these are, these are some of the educational materials which you can discuss with the patient. For the same option, you can have a safer option rather than going for red zone foods. This is the hand guide for serving. And food exchange is a formula where equivalent foods are food equivalent units are designed to facilitate easy variation in diet. So similar food types can be placed in exchange groups, and I'll be showing some of them. For example, a carbohydrate exchange, one slice of bread can be exchanged for 1/3 cup of rice. Foods from different groups cannot be interchanged. So one slice of bread cannot be changed with 1 ts of butter. So similar group food changes should be. So this is the example on the exchange list, and I'm sure you must all be aware of this. Fruit exchanges again, and carbohydrate counting is a thing which we practice every day. So daily calorie should depend upon the body size, age, weight, height, activity level, genders, and other conditions such as being pregnant. And we need to assess all these things. Now, a few words about estimating fat intake. So if you ask for ghee rather than oil, that's not a very good idea. In regions like North India, ask for use of coconut, them groundnuts, and other sugar. So these are some of the things which need to be. How do we estimate calories from a recipe? All along the Western India, most of the recipes will have sugar or jaggery in them unless specified. So we need to understand that. Most of the recipes in South will have coconut unless specified. Most of the recipes from North will have more oil or ghee in them. And therefore, while estimating calories from a recipe from the particular community of the patient should be considered, and leading questions should be prepared and asked. So chole in Maharashtra would be made with coconut, a little coconut and sugar in Gujarat, no coconut but a little more sugar than in Maharashtra, and in North India you would have ghee in place of all this. So these are some of the understanding food recipes and food patterns of different parts of the country. So we need to understand that. We also need to understand the importance of empty calories now, which are junk foods which do not have empty which account for empty calories. It includes any food which gives too many calories from fats and sugars. So too many cups of tea, coffee, cold drinks, juices, foods like chura, chakli, from Maharashtra, matri from, in Marwadis, samosas from Bihar and Uttar Pradesh and Delhi. So these are empty calories. Now, especially now you have jumbo vada pav, Mac Maharaja, so big foods, a bucket full of cheese fries. So these are some of the empty calories which should be taken care of while educating the patient. A big no should be discussed about these empty calories. Coconuts, so cold drinks, these are all empty calories. So normal requirements are according to the age and according to the activities. So different types of status of the food, different status of the individual can have different calorie requirements. Like in pregnancy, calorie level guideline is 30 kilocalorie per ideal body weight for pre-pregnant, 36 kilocalorie per kg of ideal body weight in the second trimester, and 38 kilocalories ideal body weight in the third trimester. Moderate calorie restriction, especially 30%, approximately 1800 calories, has been shown to reduce macrosomia without neonatal morbidity or maternal ketonemias. So this is a classical 1500 calorie dietary plan, and I'm not going to discuss. Just to highlight that glycemic index of food is the understanding of scale of food, certain foods which can cause increase in the sugar levels instantaneously. So individuals, food which have the potential of raising sugars instantaneously have high glycemic index, which is 90, and like maida, bread, sugar, cornflakes, baby corn, grapes, chiku, custard oil, a custard apple, mangoes, these are high glycemic index food. And low glycemic index foods are parboiled rice, usna chawal, milk, ice cream, peanuts, tomatoes, apples, dried legumes, nuts, barley, rajma, soybean, fructose, all cereals and pulses. So if you have the option of choosing between high glycemic and low glycemic index food, a low glycemic index food of less than 70 should be exchanged in place of high glycemic index food. So high glycemic index foods should be avoided as far as possible. Now there are certain functional foods in diabetes. Methi seeds, they have the potential of controlling blood glucose and cholesterol. Oats are rich source of soluble fibers, especially beta glucans and anticoagulants and bioactive compounds, including carotenoids. Nuts are again friendly. They have a rich source of high biological value proteins, bioactive peptides, functional fatty acid fibers, phytosterols, polyphenols, tocopherols, and other antioxidant vitamins. Soy proteins, omega-3 fatty acids, and flax seeds are very good functional foods for diabetic individuals. The free foods that can be consumed in unlimited amounts to satisfy hunger, like raw vegetables in the form of salads, tea, coffee without milk and sugar, plain lemon juice, thin buttered milk without sugar, clear vegetable soups, tomato juice without sugar. So these are free foods. Suddenly, if the patient feels hungry and wants to have some food, so these are the options which can be taken freely at any time. Now, we also need to understand while managing diet, the 6 days do's and don'ts. So for type 1 diabetes, you should take the usual insulin dose and do not omit or reduce the dose. Eat according to how you feel and what food you can tolerate. Have small, low-fat snacks and at regular intervals. Have sips of fluid. Test your blood sugar frequently. Test your kidney for ketonuria and contact your doctor if it's essential. This is the prescription for type 1 diabetes. For type 2, again, take your medicine and insulin at the prescribed dose without alteration. And if you cannot have a meal, have a frequent low-fat snack. Drink plenty of fluids to avoid dehydration. Test your blood sugar frequently and test your urine for ketones. And of course, if there is a problem, you need to contact. So now let's talk about the remission and diet. So this was a study in a study by Bowman et al. A low-calorie diet, the LCD of 900 calories, including 115 gram of protein, led to a significant improvement in glycemic control that was mainly attributed to improvement in insulin sensitivity. So this trial showed that LCD or low-calorie diet can have significant improvement in glycemic control. In 2003, the Look Ahead trial randomized almost 5,000 overweight or obese patients with type 2 to an intervention group that received either an intensive lifestyle intervention, which included calorie restriction, which is my interest, and increased physical activity, which Dr.Sudhir Jha's interest. So one arm was me and Dr.Sudhir Jha, and the other was our usual diabetes support and education group. So post-study, this study revealed that at 1 year, almost 11.5% of the patients which in our group received complete remission, which was partial or complete. Now, interestingly, this remission was ill-sustained, and it decreased over time by 9.2% at year 2 and 7.3% at year 4. However, when we compared this remission rate with our group to the usual group, again, our group had a remission rate which was more than 3 to 6 times higher than those achieved in the DSC group. So however small effect it had, it was significant as compared to the usual diabetes support and education group. So intensive lifestyle intervention like food, calorie restriction, and increased physical activity can have has the potential of remission. So this was again a trial in 2011, which was a reversal study by Taylor and colleagues, where some of the intervention arm had a low calorie diet of 600 kilocalories. They not only normalized glucose, HbA1c, and hepatic insulin sensitivity within a week, but also led to decreased hepatic and pancreatic triacylglycerol content and normalization of the insulin response within 8 weeks. However, this was not sustained, but over a quarter of patients had an early recurrence of diabetes. So this study again could not maintain reversal for a pretty long time. Now, when these patients were studied again for a longer period of time with 8 weeks of a very low calorie meal replacement, followed again by 2 weeks of solid food replacement and a weight maintenance program of up to 6 months and 6 months, this study showed that a fasting glucose was found to be less than the diabetic range, and the patients who maintained a fasting glucose of less than 126 were labeled as responders, while other categories were categorized as non-responders. At 6 months of time, 40% of the patients who initially responded to the intervention were still in the type 2 diabetes remission, and the majority of those who remitted had a shorter diabetes duration of less than 4 years. So in a low-calorie diet arm, which was followed by solid food replacement, the remission rate continued for a pretty long time. So this is one of the this was one of the earlier dietary and intervention lifestyle arm studies, which was followed by the direct study. The direct enrolled a sample of almost 306 relatively healthy participants with type 2 diabetes and who were on insulin with a diabetes duration of longer than 6 years. They were excluded. So these were healthy participants with type 2 diabetes. They were clustered and randomized to either standard diabetes care or an intervention using low-calorie meal replacement diet for 3 to 5 months, followed by a stepwise food reintroduction and a long-term weight maintenance program. At 1 year follow-up, 46% of the patients met the study criteria for diabetes remission. And at 2 years, the remission rate was 36%. So this is the graph which is showing that. So a remission is a dream coming true if intervention is intensively instituted, that includes dietary intervention along with physical activity. So to summarize, dietary control plays a vital role in diabetes self-management, and we need to understand that a diabetes can have better better control if diabetes diet is maintained. It's fully understood, and the care providers give you a proper advice. Thank you very much.
Thank you, Dr. Das. Well, excellent said by the Dr. Das. Now I have one question, Dr. Das. You said the protein requirement is 0.8 gram per kg body weight per day in a diabetic patient. What we should do in the case of diabetic nephropathy? And the second question is there any change in the carbs, particularly in the gestational diabetes?
Yes, for patients who have CKD, the protein content goes down, but that is not neutralized. So the recommendation is 0.6. So from 0.8, it goes down to 0.6 gram per kg body weight. For our gestational diabetes mellitus, I have already shown that the depending upon the gestational age of the patient, the calorie requirement changes, and we need to take note that 50 to 60% of the total calorie intake should be born from carbohydrates.
Okay, thank you. Now I'm asking Dr. Burma sir to say something. Burma sir.
Now, Dr. Amit has really presented very excellent paper. Really, he has labored hard in this presentation. Now, he was very particular about the dietary modifications which is required in diabetes, particularly in T2DM. And but there are rough things that we see practically that I have found that, and I found somewhere also, that it is the mixed diet which is the most important thing. Mixed diet means any diet which contains fibers, fat, protein, carbohydrate, minerals. And I think any person who is diabetic for 2 or 3 months or more, he is already in restricted diet, and he already starts taking that. He has just one slide was very important, that ADA has recommended plate system. Half of the plate should be with vegetables, then with the cereals and all those things. So if a diet is mixed, then there is no problem. If a person is taking roti, dal, bhat, and vegetables, roti, dal, and fruits, then these things contain all the minerals, all the fibers, all the proteins, all the carbohydrates, all the fats. If this is the normal diet all over in our situation, then I don't think that very much dietary restrictions need to be recommended for them. If this is some dietary restrictions need to be highlighted, but they are already taking a good diet, if not very good diet, but they are already taking good diet if it is mixed one, because all the mixed diets have lower glycemic index, because if any carbohydrate which is mixed with fat or protein, it becomes a food of lower glycemic index, and fiber also. And so, he has already highlighted all these things. So he has presented very well. One thing that in my mind comes, all these elite gathering is here. I want to say, and I want to ask also, is the word blood sugar genuinely right or not? Because I know that all of us know that blood does not have any sugar. Sugar is never present in blood, but we are using all over the word blood sugar. So I want to know whether the sugar word should be banned from this diabetic blood sugar examination or not. We should use blood glucose because sugar is never present. Sugar means sucrose. Sucrose is never present in any human being in the blood. Okay, any expert
in
this
England, it is blood glucose. It is told as a blood glucose, and in America,
Valid question.
you use it as blood sugar. So it is basically a colloquial use of sugar and glucose. That is, you can, but in England, it is absolutely used as a blood sugar.
Ajay sir's comment
glucose.
on this.
This is a very difficult question. I will refrain from making any comment, but I have some very important questions to ask to you after your excellent presentation. Can I go ahead?
Sure, sir.
There are many fanciful diets recommended in diabetes with or without obesity, particularly with obesity, with respect to reduction in the body weight. And I'm not going to ask you any question about those keto diet and Atkins diet. So many fanciful names are there. But one particular dietary regime which has been recently recommended over the last 5 to 10 years is based upon very extensive research. And in fact, a couple of years ago, the Nobel Prize went to those scientists who actually worked on the process of autophagy. And autophagy is achieved brilliantly by the process of intermittent fasting. So I would like to seek your comment about intermittent fasting, role of autophagy in controlling diabetes, coronary artery disease, in fact, improving lifespan of an individual. How practical is it to institute intermittent fasting and what are the benefits?
Sir, we have had a very nice lecture on intermittent fasting by Dr.Sudhir, sir. I'd request him to answer this question, sir.
Okay, Sudhir, please go ahead.
Sir, as far as the diet concept is concerned, I think it is the most controversial one. It is agreed that this is number one priority. But even the traditional recommendation of 3 principal meals, 3 small meals, that is being challenged at. And all types of keto diet and all those diet, Atkins diet and everything, they don't have much to offer.
No.
And it is said that we say breakfast like a king, like that. This concept is also not heavily supported by the scientific data. And we have perhaps yet to recover, yet to know what is the exact diet we should be following. As far as the concept of intermittent fasting is concerned, and the concept of autophagy is concerned, this is very interesting. And in fact, now we know that we have so much therapeutic modalities for the treatment of diabetes mellitus, but of them, the most important and most effective is bariatric surgery and the very low calorie diet. As an expert international diabetologist, sir, you know that in the experimental models, in the animal studies, it has been seen that very low calorie diet, you start on the day 1, and from the second day, the peripancreatic the fat starts melting. Similarly, if we are feeding a person with the 6 meals, 3 major, 3 small meals, spread over 24 hours, we are constantly putting glucose into the system. The concept of intermittent fasting says that, particularly when it is combined with carbohydrate restriction, that there is a period of fasting where the glucose is less. So if the body uses energy, it has to seek the alternative metabolism, the fat metabolism. And that makes sense to the common people. The common perception says that this is okay. Only thing which we are seeking for is the scientific validity. And as far as the scientific validity is concerned, we don't have very much scientific validity for a big breakfast. We don't have very much a strong scientific validity for spread out meals. So I will leave this issue as that. And I feel, to my common sense, it appears good that intermittent fasting combined with carbohydrate restriction may be recommended in the future. And as at present, we are not recommending it. And the matter is yet to be settled. And we need to think over it.
Okay, thank you very much. I can only tell you that there are a number of patients in my practice today who have actually proved me wrong. I always advocated what exactly you were saying, and they came to me after reading lots of papers on intermittent fasting and watching the YouTube, etc. And particularly after that Nobel Prize with reference to the autophagy and intermittent fasting promoting autophagy, etc. And I can see that amongst all the various varieties of dietary restrictions, etc., this is one which is very attractive to follow, easy to follow, and at the same time, there is absolutely no doubt that within 6 months' time, there is a weight loss of 6 to 10 kilograms. There is absolutely no doubt about it. And when you talk about intermittent fasting, let's the concept be very clear. We are talking about 16 hours of no food and 8 hours of any food. So it's not carbohydrate restriction or anything. Say, for example, you wake up in the morning and till 1 o'clock, you don't eat anything. And from 1 to 9, you eat whatever you like to do. And 9 o'clock, after having your last food, you go to sleep. And obviously, you get up in the morning and don't take anything till 1 o'clock. It could be 1 to 9 or 2 to 10, whatever you select, that's your choice. And I have seen brilliant, benefit in terms of weight reduction, in terms of diabetes control, etc. Autophagy is something which needs to be proven. But when you say that the data, I think in the last 2 years, humongous amount of data have arrived with intermittent fasting and mostly pointing towards the benefit. Now, whether it will be incorporated in the ADA or other guidelines in future, that you are absolutely correct. We have to leave it at this point of time because we need obviously more data. Yes. When we have more data, maybe this will be one of the path-breaking researches in the dietary aspect of management of type 2 diabetes and obesity.
Sir, talking on this, I will like to elaborate on this point that 16 plus 8 is the most popular method. Right. There are other methods also.
Yeah, sure. Yeah.
Alternate day fasting, 5:2 fasting. When you observe fasting on the 2 days with 25% of the calories, on rest 5 days, the usual calories.
Right.
In the purest form, yes, sir, you are right that calorie restriction and the type of food is not important. But gradually, with the evolution of the concept of intermittent fasting, we have come to learn that maximum benefit of intermittent fasting is possible when it is combined with the carbohydrate restriction.
Okay.
There is one warrior diet also, where you take small quantity of food all through the day and a large meal at night. So that is
No.
That's also one type of intermittent fasting.
No. Amit, I would like to put my perspective on this. Warrior diet is that all calories taken within a window of 4 hours.
Major
feeding.
So we have a dietitian also. She likes to talk on this topic.
So myself Supriya. सर मुझे यहाँ पे ये बोलना है कि जैसे for the diabetic patient, what I used to do, what we dietitian used to do, like we have applied keto diet and it's a very effective. और keto diet को जब हम लोग patient पे apply करते हैं तो वो directly we don't go for keto diet, sir. We used to take list of parameters are there like CBC, serum creatinine, blood glucose, serum lipids, serum uric acid, serum protein, SGOT, SGPT, urine crystal, pre-creatinine. These 9 are the parameters which we used to check, and we used to do prior pre-counseling. Along with that, when the results come, in few of them we used to correct along with the doctor suggestions, and then only we go with the keto diet. और सर keto diet में ये है कि it's like Dr. Nathan है मुंबई में, जिन्होंने इसका सेंटर स्टार्ट किया है. अंडर हिम ओनली डाइटिशियन आई टुक ट्रेनिंग and started with this diet, and there are lots of good results in the diabetic patient, which we all have seen. So there are so many things which मतलब अभी इतने कम टाइम में सर मैं अभी यहाँ पे बता नहीं सकती हूँ. और यहाँ पे सर जो हम लोग करते हैं, 1 second, we have
Dr. Dubey, you are there?
So 70% fat, 25% protein, and 5% this one carbohydrate. With this, there is a proper like guideline and proper chart we used to prepare, and everything is everything is explained to the patient before doing all this. And we used to take consent also along with this. हम लोग उनको ये भी बताते हैं कि बीच में अगर आप एक स्वीट से कुछ भी है वो भी अगर कुछ लेते हैं तो हमें प्रायर इन्फॉर्म करेंगे, so that during the washout phase and fine tuning phase and the tapering phase हम लोग उसको मॉनिटर करते हैं. कहीं भी अगर उसमें अप डाउन होता है तो अगेन हम लोग उसको वॉशआउट फेज से स्टार्ट करते हैं. तो ये बहुत ही अच्छा है जिसका अभी मतलब लाइक बहुत सारे डाइटिशियंस और बहुत सारे लोगों के इसके बारे में सर अवेयरनेस नहीं है. सो आई थिंक कि मुझे अगर एक अपॉर्चुनिटी आप सर लोग अगर देंगे तो आई वांट टू लाइक प्रेजेंट with for keto diet, sir.
Okay, Supriya, your point is well taken. Your point is well taken, and keto diet may be one of the things which we need to discuss about. And as I told you, that as far as the diet concept is concerned, it is far from settled. And okay, in one of the future endeavors, I will like to give you an opportunity to talk on that with discussing with my colleagues. And as for now, we were talking about the intermittent fasting. And as the Ajay sir said, that the fasting gives the chance for autophagy. Autophagy is the clearing of the cell debris in the fasting state. And that is a great concept to have. That may have the anti-aging repercussions. And as far as the keto diet is concerned, it has been very much useful in certain situations in resistant type of epilepsy, but it has got negative points also. So we'll give you one session to talk on that and we'll discuss the issue.
Chairperson, may I come for a minute?
Yes, sir, please do.
Yeah, wonderful. Yeah, wonderful things are going on. Another very comprehensive presentation. I'll just say about one very simple, intervention. Just changing the sequence of diet. First taking protein-rich diet, then vegetable, non-starchy vegetable, and then cereal. And there is a wonderful study by Osama Hamdi. It does wonderfully well. We are doing on many patients actually. Not changing much, just the sequence.
Correct. Protein first or protein first or fiber first?
Protein first. Protein first. Okay, maybe any vegetable. Then go for the vegetable, and that
Jocelyn,
And last is cereal. And he has shown wonderful study that GLP secretion goes up, GLP level goes up, insulin level goes up, sugar level of course comes down, and some studies have shown glucagon level comes down. So I think it is a very simple thing to do, and we are doing on many patients are getting good result. Those are non-compliant. We say, okay, take everything, but take like this. Fat, irrespective of fat, maybe whatever fat, that body fat was not restricted, it was allowed to take as it is. So this is a very nice way of changing things by changing the sequence. Very doable thing, very simple thing.
Unfortunately,
that is an excellent input, sir. That is an excellent input. And I don't know whether my assistant professor, Dr. Dubey, is there or not to say. Dubey, are you there, Dr. Dubey?
Yes, sir. Yes, sir. I'm here. I'm here, sir.
I will give a small introduction about Dr. Dubey. He is my assistant professor. He had rheumatological problems, consulted so many doctors, and all those issues he will tell himself. And he was so frustrated, even despite treatment at CMC Vellore for ankylosing spondylitis and so many things, taking biologics. He was not improving at all, and then he switched over to vegan diet. What is vegan diet and how he manages with vegan diet and how he improved, I will like he to elaborate before this elite audience. And I frequently crack a joke on him, Gopi, तुम अपने किचन को किराए पर लगा दो. He goes on a strict vegan diet and he has improved tremendously. Dr. Dubey, please.
Sir, very good evening to all of respected seniors. I am Dr. Dubey, Assistant Professor in Department of Medicine, Darbhanga Medical College, and working under Dr.S.C.Jha, sir. I am suffering from an autoimmune disease ankylosing spondylitis for last 7-8 years. And I wander here and there throughout India to eminent rheumatologists as well. But I didn't get any significant improvement. And I got 2 episodes of a systemic flare of ankylosing spondylitis, 2 episodes of massive knee joint effusion, and I suffered fever for 3 continuous months in December 2019. I was admitted in CMC Vellore for 10 days. I got injections of biologics like golimumab for 4-5 injections. Didn't get any significant improvement. I was bedridden for 6 months. I was not able to go for my daily routine activity. I used to have support from my family members to go for even a daily routine activity. I was out of my walk. Then I searched out, is there any way to come to the active lifestyle? Then I searched many things, and then I came to the conclusion this raw diet might help me. And for last 2 years, I am on a strict intermittent fasting, even 16 hour more, and 8 hour of eating window. And I am on only raw vegan diet, fruits and salads. In the beginning, I started my journey with 72 kg. I lost up to 28 kg, became up to 44 kg, and right now I am 52 kg. And back to my active lifestyle with little bit of pain and sickness. This is not hampering my daily routine activity, and lots of problem improved. I was suffering from chronic sinusitis, bronchial asthma, used to take bronchodilators, and severe migraine, used to take 2 or 3 tablets of anti-migraine drugs and prophylactic, but didn't work a lot. And since last 2 years, I have not taken even a single pill of any pathies from including allopathic sciences or homeopathic or Ayurveda or nothing else. Only intermittent fasting and raw vegan diet has done a lot with me. Even this diet, I am just with a little bit of modification. I am applying in my mother too. She was diagnosed with breast cancer 3 months back, and little bit of lifestyle changes. She has a lot of symptomatic improvement. More than 90% of symptom has improved in my mother too. She is 76 years of age. So this is all my journey, and in my journey, Dr. S.C.Jha sir has supported me a lot. Many of my colleagues, they have commented many a times, मर जाओगे यार, protein चढ़ानी पड़ेगी, and all my blood parameters are within normal limit. Even vitamin D and vitamin B12 yet. Might I may be vitamin B12 deficient in upcoming days, might possible with raw vegan diet. This is the one drawback with this strict raw vegan diet. That's all my journey. And thank you, Dr. S.C.Jha sir, who has given me the opportunity to share my experiences that I have observed in my last 2 year journey. Thank you, sir.
Comments, please, from the elite panelists.
Wonderful, Dr. Dubey. It was one of the most important CME of the RSSDI Bihar, that many of the dietary supplements, including the real-time knowledge of vegan diet or the impact on the day-to-day practice, or even in the experiencing the same type of thing in many patients. So wonderful, Dr. S.C.Jha sir and Dr. Dubey. Hope you will spread or you will work with RSSDI Bihar chapter to have a vegan diet and other diet preparation to find out the way which diet should be most suitable to our part of the world. Thanks a lot.
One thing is very clear, which I was talking about, but I left it midway, that of all modalities of the treatment, bariatric surgery and very low calorie diet, they have proved to be the most effective one. And both suggest that calorie restriction, the exercise, and that modification may be the solution to this complex multifactorial disease. If not the complete solution, at least the major partial solution.
And now it is time to conclude, sir.
Yes.
Excellent CME, and I saw that Dr. Subhash's wife is telling something to take food, and so it is better to conclude. So Subhash.
Yeah, it was great to see all the who is who of diabetology is still with us. Ajay sir, Supriya sir, Vikas sir. I think this is one of the longest CME we have. We have crossed almost 2 hours, and still the interest is on, and nobody is ready to quit. So except me, I believe. So I'll
You can also go for the intermittent fasting.
No, actually, I will start next day intermittent fasting.
So thanks a lot for everyone's interest and blessings. I'll request my treasurer, Dr. Atul Kumar sir, to give vote of thanks.
Pranam sir, to everybody. Good evening, ladies and gentlemen, and my respected seniors and dear juniors. It's my honor and privilege now to give vote of thanks to all who helped to make this scientific session in such a virtual meeting, first time being done by Dr.S.C.Jha sir. And it's always privilege to give such a vote of thanks to our respected sir, Ajay Kumar sir, who has been path pradarshak for us in all the means, from my student life till now, whatever things are there, what is going ever in the Bihar chapter is just because of him, what I feel. And we must give thanks to Sudhir Bhandari sir as a chief guest, who has given the precious time, and he has shared his knowledge and he has shared with us. Thanks to all the speakers and chairpersons also, those who have participated and given their lights to the seminar. And especially I must thank Dr.B.K.Singh sir, who has masterminded this frame, and he has started in such a nice way the scientific forum, what we have decided a month back, and it has been presented right now with the help of you all. Thanks a lot. And one more thing, I don't know whether I should tell it in this dais or not, but being a treasurer, I must say that with the effort of Dr. B.K.Singh sir, we have today got 5,37,000 rupees from the Central Committee in the Bihar account. Thank you, sir. Thanks a lot, sir. And for
Thank you, BK and
I must thank Dr. Ajay sir for again giving lightened us for this path. Thank you, sir. Thanks a lot, sir. Thanks a lot for your giving your precious time.
Thank you, sir. And I also thank sponsors of this meeting, Mr. Arjun Singh and Vimleshji, for providing logistics to this meeting. So good night and thanks everyone.
Good night, everybody.
Good night.
Good night.
Good night.
Good
night.
Good night, sir.
Good night,
Good
sir.
Thank you.
Good night.
तो सब लोग चले गए विमलेश जी, अर्जुन जी?
यस सर।
तो इसका रिकॉर्डिंग होगा तो देखिए, डॉक्टर साहब मांगे भी हैं।
जी सर, यस सर, रिकॉर्डिंग है।
तो एक बार हमको भी भेज दीजिएगा तो रहेगा रिकॉर्ड।
और we'll share the link to that, sir, recording link. Thank you, sir. Good night, sir.
Thank you. Thanks a lot. Good night.
Vimreshji, should I end the meeting?
Yes, madam. Please close to that session.
Yeah. Thank you.
Thank you, madam. Thank you very much for your helping.
Anytime. Most welcome.
Thank you.